Ensuring Equity Across the Life Course, hosted by the Office of Health Equity, DC Health.
Good morning, everyone. I hope you are enjoying this wonderful transition into fall. My name is Autumn Saxton Ross, and I will be the moderator for today's panel, Ensuring Equity Across the Life Course. Please make sure as we're continuing, if you have any questions, we'll have about 15 minutes at the end for questions. So please make sure that you submit your questions in the chat, and we'll be able to make sure that we get to those. So again, my name is Autumn Saxton Ross. I am on the Mayor's Commission for Health Equity. Currently, I am the Vice President of Education and Chief Equity Officer at the National Recreation and Parks Association. We have a wonderful panel ready for you today. We have a host of leaders that have really been preparing our city for health equity and making sure that we live and breathe health equity, not just in policy, but in implementation on the ground. So we'll be joined today by Dr. Arno at the DC Department of Health, Dr. McClaskey, who works also in the DC Department of Health and the Family Health Bureau Chief, and Dr. Elam, who is also on the Mayor's Commission on Health Equity and is the CEO and Plan President in Merit Group. And you'll get a little bit more information about them as we continue. So to give you an outline of what we're going to go over this morning is that we'll start with an introduction, make sure you understand our objectives for this morning and really frame our conversation. Then we'll move on to a more in-depth discussion about health equity in the district and the 9 key drivers of health equity in Washington, DC. Then we'll move on to some specifics in maternal and infant health, really talking about how equity is informing the choices that we're making when it comes to maternal and infant health in the district. We'll move then into integrating equity, so what it looks like on the ground and how it intersects with healthcare and finance. And then we'll end with questions and answers. So if we think about ensuring equity across the life course, it's important that we continue to stay rooted in the social determinants of health and really think about how everything is health policy. All policies are health policy, and continue to have the conversation of not just health in the terms of health care, but health in the terms of where we live, learn, work, and play, and help everyone understand their role in producing health and making sure that everyone thrives in the district, including mothers and children. So let's start to connect the dots. Our learning objectives for this morning is to learn about the root causes of health inequities here in Washington, DC, to understand the role of the 9 key drivers in creating opportunities for health, and to connect the dots, to know how persistent non-health inequities impact maternal, infant, and family health, and create barriers to health and equity across the life course. So we're going to go ahead and get started with our first presenter for this morning. Dr. Annetta Arno is an experienced public health professional with a track record in the field of health equity. She oversaw the publication of Louisville's 2011 inaugural Health Equity Report and the development and delivery of the updated version in 2014. She also, with funding from the Kellogg Foundation, convened, sorry.
Go ahead, keep it. That was me.
Oh. And with funding from the Kellogg Foundation, she convened over 100 folks from Louisville on healing possible quorum. She was appointed the inaugural director of the DC Office of Health Equity in September of 2015 and continues to leverage a health in all policies framework and was my former boss. So I would like to hand it over to Dr. Arno.
Well, good morning, everybody. Thank you so much for joining us. I'm really excited to be doing this work. The work that we do both in the district and the Office for Health Equity, plus the work that we do as part of the Mayor's Commission on Health Equity are really critical as we think about what drives health and the importance of the 9 key drivers. I'm going to go very fast. Really, what is different about an Office for Health Equity in the vein that we've developed is that we look what I call beyond healthcare and health behaviors. It's all the other things that drive our health outside of traditional thoughts about what drives health. So what is health? Health for us at DC Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. So it's really a very broad, not health care or health industry kind of thought process. When we think about what drives health, we want to look beyond disparities. We also want to look beyond traditional notions of equality and move towards equity and what that means, towards what we call an equity-informed approach to population health. So you'll learn some more about it. I'm going to go fairly quickly, but the bottom line is that 80% of what drives our health has nothing to do with healthcare or our health behaviors. Only 20% of what drives health happens in the doctor's office. So there's a lot more work for all of us to do beyond what we traditionally think of as health. Bottom line is, if you hear nothing else from me today, here are the 6 things you have to remember. Key insights. Health is more than healthcare. Health inequities are neither natural nor inevitable. I don't know why it's... Your zip code may be more important than your genetic code for health. The choices we make are shaped by the choices we have. So that means that if the doctor says to you, you need to exercise, and you live in a circumstance where there's no place for you to exercise, or it's not safe for you to exercise, the point may be moot, is really what we're saying, right? So we may know what we're supposed to do. It may not be a real option. Structural racism acts as a force in the distribution of opportunities for health. And I'm going to say that again. Structural racism acts as a force in the distribution of opportunities for health. Very critical to know. Ultimately, all policy is health policy. So whether we make policy in transportation, employment, anywhere else, that actually impacts our opportunities to be healthy. So that's the most important things. We think about it in DC as being these buckets. So this is kind of a peeling back the onion a little bit. So you can see 20% are clinical care, but we can see the biggest amount of this, 40%, is social and economic factors, right? Education, employment, and income, and all of those things. But it's also more than that. It's what creates those differentials. It's the structural determinants of health. What causes these distributions in the first place that we frequently ignore? So we need to think beyond that. So what we've done in this inaugural Health Equity Report is to really think about these 9 key drivers, and I've listed them here. What is unique about how we've presented it, instead of simply staying at the 8 wards level, we've looked all the way down to 51 statistical neighborhoods. We've correlated the data in terms of life expectancy at birth. So it's a cross-cutting kind of way of thinking about it. And we're looking at the social and structural determinants of health. What that looks like is that if we start thinking about even how we live as a community, right? We know we're many years off, 50 years plus, since several things became illegal, but we still have race and ethnicity driving where we live. So in these 4 graphs of the district, what we're seeing is that predominantly non-Hispanic whites are living on the west side of the city. Non-Hispanic Blacks are living on the east side of the city. Hispanics are living up in the upper northeast. And then non-Hispanic Asians are kind of living more in the kind of around the parks and those kinds of things. So despite what we may think about what has happened in our city, we are one of the most segregated cities in America. And it would take literally 70% of us would have to move if we were theoretically trying to have an equal distribution. So that is the underlying driver. When I talked about structural determinants, that's really what is happening in terms of racial inequities. Frequently across the world, we can think of infant mortality as being a bead on the health of a community. And what we're seeing here in the graph on the left is that even though the orange line in the middle, everything is going downwards, everything is decreased. As we've seen a nearly halving of the amount overall of infant mortality. There's still significant differences. For African Americans, it's still 3 times higher, nearly twice of some, and three times higher of whites. We see significant numbers of preterm births, etc. And what we're seeing is approximately 44% of infant deaths to non-Hispanic Blacks are related to being born preterm, being born too soon. So that just sets the stage. If we look at the leading causes of death in the district, the 10 leading causes, we know it's very similar to the rest of the country. So heart disease and cancer take up 25 and 22%. But what we see distinctly on these two maps is that even though they are approximately about the same overall, we see different patterns by the 51 statistical neighborhoods. So everything is patterned in the district. I first showed you some of the things by race. If we look at accidents and injuries and Alzheimer's, we're seeing a different pattern. What we know is that accidents are happening to folks who have jobs frequently that put them at greater risk. And you only end up dying of Alzheimer's if you live long enough to have that benefit. So again, we're seeing a different set of patterns. So again, the issue here is really differential patterns of outcomes depending on whatever issue we're looking at. So I will now look, I'm trying to make sure my slides go forward. Yes. So ultimately, oops, that went too fast. Ultimately, if we bring all of the 10 top leading causes of death in the district, you put them all together, ultimately what you get is what you see on the left-hand side, that we have differential opportunities for health in terms of length of life. You can see in the reddest of the red statistical neighborhoods, people are living up to nearly 90 years on average, whereas in the pale, faded out places, we have folks in some neighborhoods living less than 70 years. And you can see it's less stark if we look at it how we traditionally have been accustomed to, but we're also seeing slight differences if we're so 21 years difference in life expectancy at birth across the district. We can then look at it in terms of those, what we call the 9 key drivers in terms of education. And what you're seeing here is folks with a bachelor's degree are predominantly skewed towards the west of the city. And if we look at folks who are living in poverty and with only a high school diploma, they're also skewed in another part. Overlaying all of this are the sizes of those red dots, which are approximating the length of life. And what you'll see, and I'm using this graph as the starting point, we're also seeing the bar graph in the center, that folks who have less than a high school diploma are more likely to report that they're in fear and poor health. And this pattern repeats over and over again. We know also that level of education, and we're not saying that people don't know, because remember I told you the choices we make are shaped by the choices we have. What educational attainment is a proxy for socioeconomic status. And that's really what is driving the clear connection between different health outcomes and levels of education. So we see that over and over. We can then look at employment, same kinds of patterns. People who live in some parts of the city have the luxury of 97% of them being employed. And in the other part of the city, we have places where we have up to 30% unemployment. And where we have 30% unemployment in those kinds of levels, we also have the shortest length of life. And we can see the bar graph in the middle that there's a clear relationship between people's perception of their health and their employment status. So all of these things repeat over and over again. Of course, employment is related to income, and we can see significant differences in terms of income inequality across our city in terms of median household income, as well as large concentrations of households who are living with incomes at 15,000 and below, and that correlation with low life expectancy. We can look at incomes, and we can talk about the district as being in our heads, we sometimes talk about it being a high income city, and on average, that is correct. Most people in the district earn, or households earn, more than 70,000 per year. But if we break it out by race, we see a completely different spread. And similarly, we can see differences in outcomes. So I guess I'm going to start with that, but basically you're going to see the same pattern. And so the issue here is a pattern that is related to segregation and related to differential outcomes. And when we look at housing, and most of us who live here think, well, the housing is cheaper over in Southeast. But it also means that because they are on lower incomes, their proportion of income spent on housing is that much higher than the rest of us. So again, We keep seeing the same pattern over and over again. If we look at transportation and what you're seeing on these maps, the darker the brown are neighborhoods where people have lower access to a private car. We can also see on the left-hand side that where our public transportation primary routes and they centralize in the city, again, differential access not only to a private car, but to public transportation, and then with the red dots on the left. And I'm going to have to pick it up. If we look at food, we frequently talk about food deserts, but it's simply not just that. Some of us live in a food desert. Some of us live in places where we have multiple options, whereas others, we have simply limited or no options, or very, very few. The places that are showing up on the left-hand side in the bright red or burgundy, those are places or neighborhoods where there's neither a grocery store or they only have a convenience store. So again, the choices we have, especially if we don't have a car, we do have limited income, is that we are stuck with those choices is what we have. And so we can also see the extent of people's reliance on food stamps and that relationship to the right-hand side. So again, we can look at medical care. We know that there's a difference in people's access and use of public insurance. We can also map in terms of people's use, ability to speak English and otherwise, and we can look at differential outcomes in terms of life expectancy. But we also can see that even though overall in the district, we have relatively high rates of insurance, insurance alone is not enough. So yes, we may all have 97% on average, but we still see differential outcomes across the board. And I should have said earlier, we've put it into the chat. You can access the full health equity reports. I know I'm going through very fast, but the whole point of this presentation is to show you that what we've got is stark variation across the city in a relatively small city. It's like 10 miles apart, but we're living next to our relative neighbors who are living completely different lives. If we look at the outdoor environment and we look at what kids are experiencing in terms of their exposure to asthma, et cetera, which is what we're seeing on the right-hand side, we're seeing that we have higher rates of asthma in the southeast and the eastern side of the city. And that's also correlating with different shorter lives. And I'll go to the next slide. Come on, yeah. If we look at community safety, which is number 9, we frequently only think about crime happening in the southeast, but really the highest rates of crime are actually in the center of the city. Violent crime and some other things happen in some parts of the city, but I challenge you to think about what is undergirding some of that stress and all of the other things that contribute to that, including suicides, which are happening all over our city. But a lot of these, what we think of suicide as also being a violent crime to ourselves, but this is all of those things are contributing one to the other. So bottom line is, if we were to line up and list all of our neighborhoods by life expectancy at birth, and we look at all of the best outcomes, and what we've done in this table is done that, we can see if we look at the best outcomes, painted in green here, it's almost a full bingo across the board for the folks who have the longest life expectancy. But those who have the shortest, it's the same thing, right? The poorest outcomes are concentrated in the same neighborhoods, and then there's a mix in between. Ultimately, what that is telling us, it's not simply it's a rich-poor situation. Every one of us, because of the way opportunities for health are distributed, are given some modicum of opportunity somewhere in that continuum, 1 through 51 of the statistical neighborhoods. So bottom line is, what we're seeing is that we have differential opportunities for health and interrelated pathways. There's a 21-year difference in life expectancy at birth. We have opportunities that show that the longest life are concentrated in opportunities in some neighborhoods. The shortest lives are also concentrated. But bottom line, it is clear that there are differential opportunities for health in the city by income, place, and of course, race. And that's kind of the end of my presentation, and I will hand over to my colleague, Dr. McCloskey. Thank you so much.
Hi, thank you for that, Dr. Arno. And so just quickly to introduce Dr. McCloskey. She is the Bureau Chief for the Family Health Bureau at the DC Department of Health here in Washington, DC. where she serves as the principal advisor to the deputy director and senior deputy director on issues related to maternal and child health. In that role, she provides strategic direction, and that includes in maternal health, newborn screenings, infant mortality, school health services, adolescent services, really anything having to do with the life course from birth for children and families. And as a board certified family medicine physician, she serves as a subject matter expert on several committees within DC and has over 10 years of experience practicing inpatient and outpatient medicine and obstetrics, pediatrics, and maternal medicine. And so it's so nice to be able to welcome Dr. McClaskey.
Thank you very much for that introduction, and good morning, everyone. Let's see, great. So I'm going to be discussing the Department of Health's approach to addressing maternal and infant health using a 7-stage life course approach. So it's helpful to kind of get the kind of background on the mission statement of the Department of Health, which promotes health and wellness and equity across the district. But specifically the Community Health Administration, we're working to promote healthy behaviors and healthy environments to improve health outcomes and reduce these disparities and the leading causes of mortality and morbidity in the district. So the framework that you see depicted here is an approach that began about 5 years ago to highlight the root drivers of infant and maternal mortality here in DC, with the recognition that this intervention, that if it focuses after birth or even prenatally, it's actually too late. So the framework is designed to improve perinatal health outcomes and is based on the overarching goal to ensure that every community understands its health risks and role in improving perinatal health outcomes. So you're going to see this bubble throughout the presentation, so I'll take a minute to go through it, as we've identified 7 core priorities that drive the programmatic efforts. So if you start at the top bubble in pink and work your way around clockwise, we have every teenage girl and woman is in control of her reproductive health. Every pregnant woman receives patient-centered, high-quality prenatal care beginning in the first trimester. Every healthcare provider has the tools and resources they need to provide quality care and manage complex social needs of women and infants. Every healthcare facility providing maternal and infant care has the tools and resources to practice evidence-based healthcare and to document quality improvement and quality assurance activities. Every newborn should receive high-quality neonatal care in the hospital and in the outpatient setting. And every parent should have the life skills and resources needed to nurture and provide for their family. And finally, every mom and dad has a safe and healthy environment to thrive and receive the support they need to promote early childhood development and learning. So this is the framework in which we're working with. So all of our work is driven by the data which is collected. So we can start by looking at some of the statistics, which you heard in the previous presentation. But specifically, if we look at the birth rate, we see a decrease from 15.5 in 2008 to 13.1 in 2019. Specifically for DC, if we look at the birth rate for women over the age of 35, it's actually increasing. But for women under the age of 30, we have seen a decrease. When we look at the total number of births in DC, it's around 10,000 for DC residents each year. So in 2018, we saw a little over 9,000 total live births. But when we start to look at the outcomes of these births, this is when we begin to see some of the disparities, which are based on the race and the place of birth. So the next couple of slides, we're going to look really specifically at pregnancy-related mortality in the District of Columbia between the time period of 2013 and 2017. So DC Health, we use these definitions of pregnancy-related death, which is defined as the death of a woman while pregnant or within 1 year after delivery, which is going to be depicted in the light blue, and maternal death, which is the death of a woman while pregnant or within 42 days after the delivery, which is going to be in dark blue. And we use this data to determine our policies and programs to prevent death, because during different time periods of death can relate to the different underlying causes, which is going to influence or maybe change our interventions that we're going to use. So as you can see, there's really the pregnancy-related death does fluctuate from year to year. And while 1 is too many, the total number of deaths during that time period is 20. So if we take a look at that center graph or the center chart in the middle, we see in 2015, we had a total of 7 pregnancy-related deaths as compared to 2017, where there was only 1. So I do want you to remember the number 20 as we move forward. So this next slide, we start to look at who is experiencing the deaths by race and ethnicity. And this is where we start to see some of the extreme disparities. So the pie chart on the top right has a total number of births in the district during that time period. And as you can see, about 50% of the births were to non-Hispanic Black women. And while just 1/2 of the births were to non-Hispanic Black women, 19 of the 20 pregnancy-related deaths, or 95%, occurred to non-Hispanic Black women. So this is in sharp contrast to non-Hispanic white women in the district who didn't experience any of these deaths. And the one remaining pregnancy related to deaths occurred in a Hispanic woman. Moving on to look at the number of pregnancy-related deaths by ward in which the mother resided. Again, we have on the top right that pie chart, which shows the distribution of births by ward. And we can see that there's an overrepresentation in wards 7 and 8 of pregnancy-related deaths. So 12 out of the 20 pregnancy-related deaths occurred in women living in that area. So in Ward 8 alone, they represented 40% of the pregnancy-related deaths. And when we look at the racial or ethnic makeup of the residents within Ward 8, we know that 92% of those residents identify as being African American. The median income is about $35,000 per year, and 17.3% report being unemployed. Again, we see a big contrast with wards 2 and 3, where there were no pregnancy-related deaths at all. In Ward 3, 82% of that group identified as being white. The median income was $159,000 per year, and only 3.4% reported being unemployed. So we saw this graph in a little different form in the presentation prior, looking at the infant mortality rate if we move along our life course. And what we can see in green, we have the DC infant mortality rate, and in purple is going to be the US, and then in orange going across the middle is the DC Healthy People Target Goal in 2020. So in 2016, there were 70 DC resident infant deaths, which corresponds to an infant mortality rate of about 7.1. And really between 2012 and 2016, there hasn't been much of a change, with the average being around 7.8 for the infant mortality rate. But it's important to note that we are above the national average. So if we look at the leading causes of infant mortality, we do have to combine 2 years worth of data when we're looking at DC, which is in the middle or on the left-hand side, in comparison to the US, just because of the size of DC. And if you exclude accidents, the main cause of infant death in DC is related to maternal complications. And this is most commonly related to extreme prematurity due to premature rupture of membranes, which is in contrast to the US population, where congenital anomalies are the #1 cause. So does it matter where you are born? And so we've already heard is absolutely it does. So the dark green areas represent the wards with the highest numbers of infant mortality rates, and that's going to be 5, 7, and 8. So while these wards accounted for about 44% of all live births, they had 64% of all infant deaths. So if we continue along our life course and we look at adolescent health, and we want to be really careful not to assume that the only thing about adolescents is their sexual health. There are other things involved with adolescents' health. We can note some very concerning trends that we've seen. So this information is taken from the Youth Risk Behavior Survey that found that 1 in 12 middle school males reported having had sex by age 11. When asked within 3 months of sexual intercourse, did they use condoms? We had 18.1% of males and 23% of females did not use any method to prevent pregnancy during their last sexual intercourse. And we do see a declining rate of condom use. So only 67% of males and 47% of females used condoms. So what does this mean as far as us trying to break the cycle? We need to be familiar with the term intergenerational trauma and what that actually looks like. So historical trauma is multi-generational trauma. It's experienced by specific cultural, racial, or ethnic groups. It is related to major events that oppressed a particular group of people because of their status as oppressed, such as slavery, the Holocaust, forced migration, or even the violent colonization of Native Americans. And so when we think about African Americans specifically, they've experienced generations of slavery, segregation, and institutionalized racism that has contributed to physical, psychological, and spiritual trauma. And we know that the effects of this can be seen in utero. So women who've experienced maternal and prenatal stress, including psychosocial stress or maltreatment, have been found to be associated with having impaired uterine blood flow, low birth rate, and preterm birth. Individuals who were products of low birth weight or preterm birth in turn have been linked with having subsequent development of hypertension, type 2 diabetes, and cardiovascular disease in the adult offspring. So what that means is what you're exposed to in utero can actually increase your risk of getting a chronic disease later in life. So what can we do to approach this and address this problem? Well, from a public health department, we can utilize this 5-tier pyramid, the health impact pyramid, which really provides a framework to improve health on a public health stage. So interventions that are located at the top tiers are designed to help individuals versus the things down at the bottom of the triangle, which are going to have more of an impact on a broader level. And you heard Dr. Arno talk about all of these social economic factors. So if you look at the very top of the pyramid, we'd be looking at encouraging individuals to eat healthy and to exercise. Moving down the period, what's going to make a larger difference is going to be addressing the social economic factors such as poverty, education, and housing. Those are going to make the largest difference and the biggest impact in order to change some of the things that we're looking at. So you've seen this already. We talked a little about that. We have to connect the dots. This is going to be one of the most important factors in order to change. And I'm specifically talking about maternal and infant care, but on a systemic and a larger level, we have to be able to connect the dots and make the changes that we need in order to move the scale to better health outcomes. So we need to look at what we actually have in DC. And you can see this picture depicts a nice idea of what the investment into primary care and quality improvement has done, especially with the support of Mayor Bowser. So we know that we have 5 birthing hospitals and 1 birthing center within DC, and soon to have another hospital in Ward 8 that's going to be equipped to handle specialty maternity needs. We have primary care and prenatal care capacity across all 8 wards, including federally qualified health centers. We do have one of the highest medical insurance rates in the country, about 97%, only secondary to Massachusetts. We have one of the most robust Medicaid programs in the country and one of the highest provider-patient ratios in the country. So these are all positive things that we have. If we look specifically at some programs that are invested in mothers and infants' better outcomes, this is just a snapshot of what we have. We have the newly established DC Perinatal Quality Collaborative, and this network of health professionals is going to be working together to participate in data-driven quality processes that are going to help improve maternity care. We have the Title V Maternal and Child Health Advisory Board, and this group meets to convene and discuss the needs and programs related to maternal and infant care. We have the Child and Infant and Fatality Review Committees. We meet monthly to discuss systemic changes that might be put in place to prevent future deaths. And we have the newly established Maternal Mortality Review Committee. And this group meets not only to just go over the data, but to really assess the relationship between the causes of death for our women. We also have the Youth Advisory Committee or Council, and this is actually bringing the youth and adolescents to the table to discuss their own issues and what might need to happen to break the cycle at that stage. It's promoting health and building leadership skills, and it's empowering our youth to become effective advocates and competent public health educators. And we also now have the law on our side. So together with the support of the mayor, DC Health created a comprehensive legislation. It's the Better Access for Babies to Integrated Equitable Service Amendment Act of 2020. And what this mandates is for all hospitals to report newborn metabolic screening, testing, hearing, and critical congestive disease screening. In addition to that, they're going to be mandated to make sure that we have protocols to support lactation services, education requirements for newborns and postpartum health, standardized discharge regulations, and clinical quality measures for obstetrical and neonatal care. Any of the hospitals who are unable to comply with this could be subject to civil fines and penalties. And lastly, we want to make sure that we have established a perinatal infant advisory committee that will report to the DC Health Director and the mayor on different initiatives. So very, very briefly, this chart, you will see it again in our next presenter, but it demonstrates DC efforts to address pregnancy-related mortality using the 5A strategy to address the social determinants of health in the communities. So the things listed in black are the suggestions, and what's listed in blue is what DC is actually addressing already. So if we look at the first category, which is awareness, we're already collecting data on maternal mortality systems and comparing them to a national level. The second bucket would be adjustment. The recommendation is to implement standardized protocols and quality improvement initiatives. Well, we're doing that by the utilization of telehealth to conduct healthcare visits and funding and supporting programs that are doing that, as well as our hospital discharge regulation protocols that will be put in place. Under assistance, the recommendation is to ask the needs of patients, their social needs, and have them participate in their own healthcare. We're doing that with listening to the youth and the advisory council and the perinatal quality collaborative group. In alignment, the suggestion is to identify and address implicit bias in the healthcare system and give support to our providers. And we're doing that with the use of our advisory boards in the maternal lab, which wasn't mentioned on the previous slide, but it's work in conjunction with the DC Primary Care Association to explicitly address implicit bias in respectful care. And then lastly, the recommendation for maternal mortality review committees. And happily, we can state that we now have a DC maternal mortality review committee as of 2019. So are all these things making a difference and kind of breaking the cycle? And happily, we can say that we have seen some changes. If we specifically look at our adolescent group, we can see that the teen birth rate has dramatically declined for this age group between 15 and 19 over the last decade. We've seen a decrease in alcohol, tobacco, and illegal drug use. And we also have seen violence and victimization and violent behaviors among high school students are trending downward. And if you remember the graph for the infant mortality rate, it does continue to trend downward. So we are seeing a difference trying to break the cycle with what we're doing. So what are our next steps in this space? Well, we need to continue with our collaborative efforts across all sectors. It's going to be important for us so that we are not duplicating efforts in order to close the gaps and make sure that we are really strengthening our robust evidence-based programs that are making a difference to make sure that we are changing the outcomes and eliminating the inequities that we see so that we can improve the health of all our district residents. Thank you.
Thank you, Dr. McClaskey. And last but definitely not least, we have Dr. Linda Elam. And she is a health policy and management leader with deep experience in financing and delivery of healthcare in vulnerable populations. Presently, she is the CEO and plan president of AmeriGroup, District of Columbia managed care organization serving the Medicaid population here in Washington, D.C. At the state level, she has served as Senior Deputy Director for the State Medical Director and helped develop and implement the programmatic changes related to the Affordable Care Act, including Medicaid expansion and the initial work to establish the district's health benefit exchange.
Thanks so much. I'm having a little bit of trouble with my screen here. So
It says Nikita will advance for you.
Okay.
Temporarily.
All right, thanks. Well, thanks again, Dr. Saxton-Ross, and it is a pleasure to be with you all this morning. My section of this presentation will review the framework, the 5A framework that you just saw for integrating social care into the delivery of healthcare. I'm going to briefly outline the importance of Medicaid as a health equity intervention and discuss the role of Medicaid in maternal and infant health, and then provide some on-the-ground examples from AmeriGroup. So thanks. Dr. Arno presented the evidence that overall, healthcare is not the primary determinant of health, and that health happens where we live, learn, work, play, and age. And then as part of her presentation, Dr. McClaskey provided an example of addressing pregnancy-related mortality through the National Academy's Consensus Study Report Framework. And that's what we're looking at right now a bit more closely, the 5 A's. And so you'll see that it centers around awareness. If you could go back, I'm sorry. I think maybe I can control now. Can I? Let's see. Okay, maybe not. The 5 A's begin with awareness, and then you'll see that they break out into mainly individual level interventions or community level interventions. And that's really important for looking at a variety of ways to approach some of these issues. Next slide, please. So again, beginning with awareness, identifying social risks and assets of patients and populations. And then those first two, the adjustment is modifying plans to meet needs, things like extending office hours or having language appropriate services. Assistance is connecting people, providing that warm handoff, if you will, between healthcare and social care. And then the next two, and I will move really quickly because I'm trying to buy back some time. I know we have some really good questions, so forgive me for kind of breezing through. On alignment, you're going to bring healthcare resources together with the social care resources. And so, for instance, a health system might invest in transportation, understanding that transportation is a barrier to accessing care. And then moving further upstream, you can engage in advocacy that looks at how to reconfigure the system altogether to better serve the people that you are caring for. So next slide, please. So here's a quick example, and here's the document that we're citing. I highly recommend it because I think you've heard a lot of compelling information indicating that in order for us to get to the health outcomes we're looking for, we really need to link healthcare and social care. And this is a transportation example, walking through, again, those individual level issues and then the community level issues. Once you have an awareness of what some of the barriers might be or where some of the assets and strengths might be. Next slide, please. So moving on to Medicaid, it's a critical player in perinatal health across the country and certainly in the district as well. It's a federal state partnership providing health coverage to people with limited incomes and some people with disabilities. In maternal and infant health, Medicaid is a key player nationwide, covering over 42% of US births. But definitely a majority of births in the District of Columbia, over 60%. I'd like to also note that the district operates the DC Healthcare Alliance, which is a very critical source of coverage for people who would otherwise qualify for Medicaid, but for immigration status. The district's progressive stance that you've heard about with regard to health coverage puts us in the top tier of states working toward full insurance coverage. But as you've heard repeatedly, clearly that is not sufficient to achieve health equity. So we have to do more and look at how we can use Medicaid to provide the care that our populations need. So an acknowledgement of the importance of Medicaid to perinatal health is the set of requirements around it. So for example, pregnant women must be covered up to 138% of the federal poverty level for up to 60 days postpartum. Most states do go higher. I would note, though, that for states that have not expanded Medicaid through the Affordable Care Act, after that 60 days, eligibility can drop as low as 17% in Texas or 18% in Arizona after the 60 days are up. That leads to greater rates or higher rates of uninsurance for women in the extended postpartum period when needs for physical and behavioral health can still be significant, as we just heard. But again, this is not a concern in DC. Pregnant women are covered over 300% of the federal poverty level. Beyond the number of people insured, the scope of coverage is really important. And again, I won't go into detail, but the guarantee of a package of core services is critical to Medicaid coverage. Core services are provided to pregnant and postpartum women. And in addition, the child health benefit, known as the early and periodic screening, diagnostic, and treatment benefit or health check in the district, is tremendously important for preventing and identifying clinical issues in children. Next slide, please. So Medicaid is largely run through managed care. That's nationwide, and largely through risk-based managed care, where managed care organizations or MCOs are paid a set rate per member per month to provide care to an enrolled population. And this is known as capitation. And one of the key principles behind a well-operating program is that by improving the health outcomes of the population, the MCO is financially sound and the population it serves is better off. As states are driving toward better health outcomes overall, they are asking Medicaid MCOs to focus more on the social determinants of health, such as housing, nutrition, education, and employment, through screening, through making referrals, partnering with community-based organizations, and other mechanisms. And this is important because typically these are not the kinds of things that Medicaid covers. But again, because Medicaid MCOs are given a per member per month rate, they're able to provide the clinical care, but also invest in some of these social care modalities that we know can help improve health outcomes. And some of those are known as value-added benefits, and we'll talk about those a little bit later. Next slide, please. So very, very quickly, the 5 A's regarding pregnancy awareness. We're asking here the March of Dimes one key question: would you like to become pregnant in the next year? And again, there are the individual level pieces, the adjustment and the assistance that will help that individual achieve her goals. If she doesn't want to become pregnant in the next year, ensuring that she's got the right family planning tools available, that she's got the right coverage to pay for those or permit her to get access to those treatments, scanning for social determinant of health needs, and also critically behavioral health needs, including substance use disorder. So individual level issues are on the left, of course, and then on the right, looking at alignment, working with the CBOs who are very familiar with the population and the resources that are available, partnering with governmental agencies beyond Medicaid. If you're looking at something like housing insecurity or food insecurity, there are other alignments to make there. And then advocacy, working overall to promote policies to improve access to reproductive health coverage and payment for social determinants of health treatments. Okay, next slide, please. Kind of rushing because I know we are really tight on time. So if I take it directly to AmeriGroup as a health plan serving the district for 3 years, in order to combine that clinical care and the social care that we know we need to have working in tandem to improve health outcomes, we need to look at population level data, such as what's developed by both the federal government and the district government. Also, we have a community resource link where we get feedback as we see what our members search for in terms of social needs that they might have, education, for example, food insecurity, and so forth. And then that can be aggregated. On the individual level, we have case management data that are compiled, the outcomes of screenings and assessments, and then outside referrals as well. Next slide, please. And so this work is done through a very wide scope. As you heard, it begins preconception, and then prenatal care is critically important, postpartum care, infant care, and then outside of just that, clinical care, looking at that as addressing social determinants of health at the same time. So a big piece of that is enrollee education, which we invest quite a bit in. Provider engagement, education, and providing incentives to providers to engage in the evidence-based practices or the activities that we believe will lead to better health outcomes. Care coordination and case management, particularly for those enrollees with higher needs, chronic conditions such as diabetes or heart disease. And then the value added benefits, as I mentioned, the kinds of things that Medicaid typically wouldn't pay for, breastfeeding support kits, mail order diapers, safe sleep kit to help address the SIDS issue that includes education and a bassinet, medically tailored meals where appropriate. And I'll just leave the value-added benefits conversation with something that we developed as a result of dealing with the pandemic in partnership with Mary Center, an OB telehealth kit that would allow a pregnant woman to provide certain data points through telehealth to her provider so that she could stay connected to care even while people were not generally going in for preventive care. So being responsive to what's going on in the environment, but at the same time, keeping people connected to care. So that was sort of lightning round. Appreciate the opportunity, and I will now open it up for the questions that I know have been rolling in.
Yes, thank you. Yes, and I'm not on mute. Excellent. Okay, so we have a few questions. The first one, I'll start with the easy one, and this is for Dr. McClaskey. Can you please place in the chat for our support team to give out to the audience how to, if folks have people for the Youth Advisory Council, can you please make sure that you send that information for the audience to be able to support young people into becoming part of the Youth Advisory Council? So that's—
Well, let me just interrupt there. So I'm excited to hear about the interest in it. It actually is a selection process. So you're not able to just kind of join it, but it is actually a selection process and an application process that occurs every year. So I can provide information indicating to go to DC Health to look up some of the services that are being done. But we are very excited that we've selected our group for this year. And so we'll be looking to look for new applications for the following year.
Excellent. So we'll make sure that hopefully Makita can send them to the DC Department of Health's website to be able to see the application process. Okay, wonderful. So a question that I wanted to talk about, we have a couple of questions around teen parenting. And so if we think about the declining levels, how can we continue to support the health of adolescents, young adults, continue to support those teen parents? And thinking about how can we support folks to break the cycles of intergenerational trauma and really promote positive maternal health outcomes in the future. So what are some of the things on the ground that are happening or we are looking to continue to do to really help young folks when it comes to a lot of these, a lot of the issues for around health for adolescents and young people?
Well, I know Dr. McClaskey will jump in, but I thought I'd just preface the conversation with that it's even before we get to that point where we have young parents, we really, my whole presentation about it being, I usually say health equity is everybody's work. I know, for example, we have high schools in the city where the graduation rate is 50%. That means that year on year, we also know that for people who don't graduate from high school, they're probably going to live 5 years shorter. So I think there's a huge role for all of us as parents, advocates, and all of the other things, and those in the education field, to really think about how important it is for us to invest in the education of every kid in our city and make sure that they have all of those things as a starting place. So that would be my starting place. And then I'd hand it over. I think Dr. McCloskey talked really well about, having those young folks who come in and talk about how it would improve for them, but then I'll hand off to others. But I really wanted to make sure that we think about it in the bigger round than simply when we come to the point of being a consumer of healthcare. It's much more than that. So I'll invite anybody else to jump in.
Sure. No, I will just add to that. Absolutely. So if we're specifically looking at adolescents in that very precious time space, we do need to talk to them about what their specific needs are and really providing role models for them so they can see something different from what they've already seen. Earlier in the weeks, Dr. Chosky mentioned talking to them about what is right with you as opposed to what is wrong with you, bringing them to the table to let them recognize that the things and the choices they're doing can infect them long term, and giving them the tools and empowering them to become advocates for themselves and public leaders. But in order for them to be successful, back to Dr. Arno's point, we have to give them the resources. So we have to provide them a space so that they are able to do the things that we are encouraging them to do. But I think really listening to them, hearing their voice, and encouraging them to think outside of what they think their norm is and shoot for other things that are going to inspire them to be healthy.
And I'll just add briefly, and so operationalizing that at the health plan level can involve, if someone needs assistance to get a GED, we can help provide that. We have educational opportunities that are also group opportunities, and there can be a significant amount of support that that folks can provide to one another. And again, I'm kind of a proselytizer about really keeping behavioral health front and center as we think about physical health, and making sure that we're also, while we're worried about the reproductive health side, that we're also considering the behavioral health side for young folks and attending to their needs there as well.
And I would encourage that, and the mental health support that they need, especially during this time period, is really going to be very critical that we're able to provide them with that sort of support, not just physical, but mental, spiritual, right, the whole package.
Thank you. And we only have 2 minutes left, so I'm going to try and throw in a question. Most of our conversation has been around maternal and infant rates as it relates to African Americans. But if we think about on the ground, what are some of the activities that are happening or specifics when it comes to the situation and issues experienced by Hispanic mothers and those that are pregnant? Do we have specific activities focused to help with those rates as well?
I can jump in, kind of going in the opposite direction right now, starting with how it works on the ground. Certainly serving the district, a very diverse community, health plans absolutely have to have culturally sensitive and linguistically appropriate services. And so that involves everything from printed material to classes that are operated to the case management staff that's working with those populations, and being a part of the community as well, bringing in staff at the health plan that really know, that are deeply rooted in the communities that we are serving is tremendously important as well. So that speaks to the Hispanic Latino population, but other populations as well. And it's critically important in a diverse environment.
All right, thank you. That was perfect. We are actually right at 11 o'clock. Thank you. So here's everyone's contact information. If you'd like to follow up and ask any specific questions, thank you so much for joining us this morning, and enjoy the rest of the conference.
Thank you, everyone.
Thank you, everyone.
Thank you.
Bye.
Thank you so much for listening.
There's a major crisis with America's health system. Millions of people, including many with health insurance, are unable to get the care they need. The solution is simple. Having access to reliable, high-quality healthcare is the way to keep people and communities healthy.
That is why 30 years ago, we created Mary Center, because we believe that everyone should have access to the best possible healthcare, regardless of their ability to pay. For us, quality care is not a service. It's a human right.
For Mary Center, quality care goes beyond just medical care. It includes access to the very best in dental, behavioral health services, low-cost pharmaceuticals, education, and social services. We believe healthy people make healthier communities. So we've decided to refresh our look to show that by connecting each person to the best possible care, we will not only improve lives, but we will strengthen communities too, one person at a time. When Mary Center puts care at the core, you can too. To schedule an appointment or find out how you can help, visit our centers or go online at marycenter.org.
This is a vaccination to keep you healthy. You don't want the measles, do you? Here's your sticker.
Protect your loved ones and they'll pass it on. Don't let COVID-19 stop you from protecting your child.
You're next, Mr. Bear. You need a flu shot.
Now more than ever, it's important your child receives their vaccines on time. Brought to you by the District of Columbia Department of Health.
Ah, good. See, it wasn't that bad.
Do you worry your preschooler doesn't walk, talk, draw, or play like other children their age? The Early Stages Center can help. Our friendly staff will assess your child's development through one-on-one, play-based activities. Early Stages will then connect your family with the educational services that are right for you. Everything is free, whether your child is in public school, private school, or not yet enrolled in school. Call 202-698-8037, a service of the DC Public Schools.
This is a total no judgment zone. We don't want parents to feel like because of X decision that they've made that they've done something the wrong way, because I know how sometimes difficult it is to manage diet and brushing. So it's important to put families at ease, encourage instead of discouraging, and making sure that they know that we are partners in their care, and not those that are there just to wag a finger or judge them about anything that they're doing. To get a call from a parent that says, I can now breastfeed my child because of you. Maybe they've been told elsewhere they'll never breastfeed their kid, and a simple procedure to do something now changes that whole trajectory for them. Or a child that may have been referred to me and no one can do anything with them, and they come in and I'm going, really? The kid walked in and out smiling, like we had a ball. And we didn't have to do anything like sedation or general anesthesia, which we do pretty often, for them. We didn't even have to do that. A simple, just encouraging, it's gonna be okay, we've got this, we're gonna do it together, let me know what you need. Just kind of thinking about families and thinking about my own family as we make decisions within our practice.
Listen, every day in America, workers are forced to make the unthinkable choice between caring for themselves and loved ones or keeping their job. You know how that can be. Beginning July 1st, 2020, workers in the District of Columbia will be eligible for paid family leave. That's right. When your loved ones need you most, you should be able to step up to the plate and take care of them. That's why DC Paid Family Leave will provide up to 8 weeks of parental leave to bond with a new child, 6 weeks of family leave to care for a sick family member, and 2 weeks of medical leave to care for yourself when facing a serious health condition. Hey, we understand that sometimes life happens, and you shouldn't have to choose between your livelihood and your loved ones. So if you want to learn more about DC Paid Family Leave, check it out at dcpaidfamilyleave.dc.gov.
Complete the 2020 U.S. Census. It is safe and secure. It benefits your city, your community, and your family. When you fill it out, you will help determine where billions of dollars will go, funding our kids' education, school breakfasts and lunches, healthcare, and Medicaid for our seniors. better social services, creating more affordable housing, job training, and helping everyone have access to food. Complete the census online, over the phone, or once you receive it in the mail. You matter. Get counted. 2020census.gov.
We've been able to really shift our care according to what we feel like the population needs. I think one of the things that makes us strong is that we provide culturally aware care. I think it helps that the majority of our midwives are of color. When we're talking about birth disparities, especially with African American women, I think that we are now entertaining the conversation about years of generational distrust with a lot of healthcare systems. And so I think that we create a safe space for that interaction, not only by having more staff of color, but also just things like our late policy. Midwives, we see our patients regardless if they're late. We see pregnant patients late and we see babies late.
Our whole family is just tied up into Community of Hope.
Hi, I'm Heidi Murkoff, author of What to Expect When You're Expecting, and you may have heard moms matter to me a lot. That's why I founded the What to Expect Project and why I'm here to support Mayor Bowser's National Maternal and Infant Health Summit, because every mom should matter. I always say motherhood is the ultimate sisterhood, that no matter where she lives, her cultural, socioeconomic, political profile, the color of her skin, every mom shares a common goal. Every mom wants the best for herself and her baby. But far too many moms, especially Black moms, don't receive the quality, respectful prenatal care they need and deserve. Too many Black moms die of complications of pregnancy and childbirth, and far too many of those deaths are preventable. And the onset of COVID-19 has increased the risks for Black moms. Gaps are widening as clinics and hospitals in rural and urban areas close, and care becomes even less accessible. And more of our most vulnerable moms I speak to every day, are falling through the cracks of care. The truth is we can take care of our moms and control pandemic at the same time. We just have to pick our healthcare priorities, and we have to stop always putting Black moms last, like they don't even matter. One way we can do that by voting. This year, WhatToExpect.com, a home to over 19.6 million moms, and the What to Expect Project have launched #MomTheVote to urge moms to speak up and be heard, to vote for those who vote for them, for maternal health care that doesn't discriminate or come with a use-by date, and that isn't paused because of a pandemic, for paid family leave that allows moms to care for themselves and their babies instead of forcing them back to work after only a week or two, affordable childcare, and so many other policies that impact their lives and their children's futures and that of their mom sisters. There's no better investment in our future than the health and well-being of our moms, all of our moms, no exceptions, no disparities. Let's stop failing our moms. Let's make moms the priority they should be.
I'm Polly Donaldson, Director of DC's Department of Housing and Community Development, and I wanted to talk about affordable housing in the District of Columbia and our affordability crisis. The rule of thumb is you should only spend about a third of your income on your housing needs. We know we have to do more in the District of Columbia.
Mayor Bowser has been a national leader in affordable housing policies and funding, but she realizes we need to do more. So she challenged the city to produce 36,000 housing units by 2025, with 12,000 affordable to low-income residents. Our first analysis is looking at where affordable housing is across the city and where it should be in the future. This summer, we asked residents to examine a map of affordable housing in the city.
I feel the distribution of affordable housing in the city could be a lot better. It seems too much of it is concentrated east of the river in Ward 7 and 8, and not enough of it in Ward 3. Ward 3 would be a perfect place to have more affordable housing. It's resource rich.
For me, housing and affordable housing is personal. I first got involved in producing affordable housing for our homeless families over 30 years ago. To me, it's all about who is your neighbor, and are we able to say that anybody who wants to be in the district, whether you've been here for 5 generations or for 5 minutes, there is a place for you in the District of Columbia.
Pregnant and postpartum in a pandemic. Anxiety management strategies for providers, communities, and families. Hosted by Ruthie Arbit.
Hello, everybody. Thank you so much for being here today. As you just heard, my name is Ruthie Arbit. I am a psychotherapist specializing in maternal and pediatric mental health. And today's session is going to be on what it's like to be pregnant or postpartum during the pandemic and specific strategies that providers, communities, and families can use to help some of our most vulnerable moms. You've already heard a little bit about me from the introduction, so I won't go into that too much. But as you can see, I've done some advanced training in anxiety, advanced training in perinatal mental health, and also advanced training in cognitive behavioral therapy, which is one of the evidence-based techniques to help moms and families that are struggling with a range of issues. From it can be effective for depression, anxiety, OCD, panic, trauma. Our schedule for today, our session is going to be divided into 4 parts. We're going to start with a background on perinatal mood and anxiety disorders. And then we're going to talk specifically about COVID-19 and the impacts of the pandemic on what are called PMADs. The next part, section 3, we're going to talk about strategies for providers and families to use to assist some of these families. And then we're going to do the last session is going to be Q&A. So down to our nuts and bolts. So PMADs, perinatal mood and anxiety disorders, refers to the mental health complications that happen during preconception, pregnancy, and postpartum. A couple of things I want to say about this. So first of all, PMADS as a term, there have been some in the community that feel like the term connotes, a mad mom, and that's the image that we're conjuring up. So there have been a lot of clinicians that feel like a better term might actually be PMD, perinatal mood disorders. But for now, we'll stick with the term PMADS because that's actually still the most common term. The other thing I was going to say is, even though here it says, a lot of times when we think about depression and postpartum depression, the image that we come up with is, a crying, sad, depressed mom postpartum. And the reality is that image is actually much, much more than that, much more complex. So we'll get into the specifics, but, these perinatal mood and anxiety disorders can begin when you start fertility treatments. They are not just depression, they're also anxiety, they're also OCD, they're also trauma. They affect moms and dads and partners. They affect adoptive parents. So this is much more nuanced than, just that initial image that we might have of a depressed mom postpartum. As you see in the bottom part of the slide, baby blues, that's what many of you might know. I went through a little bit of my professional credentials earlier, but I'm actually also a mom of 3 and a local DC resident and therapist. I'm a mom of 3, and my youngest was actually born right before the pandemic, but I've sort of had a very close window into what it's like being a parent of a baby in the pandemic. But anyway, the second part of this slide is on baby blues, which is what many of you might know, which is, after a mom has a baby in the initial postpartum period, this is usually about 2 or 3 weeks postpartum. That's when moms are really weepy, right? So I remember when I had my first kid, when I was sitting down to dinner one night and there wasn't any salt at the table, and I just started crying and crying and crying, right? So with baby blues, very natural response to having a baby, a hormonal shift. We say, some people say 50 to 80%. My supervisor actually jokes that it's only 80% because the other 20% are lying, that actually, baby blues are pretty much ubiquitous. So we have baby blues on the one hand, and then PMADS on the other hand. Those are two very different things. So one of the things that we're going to talk about a little more is how to distinguish that. So what are PMADS? We have a couple of slides of this. So first one, PMADS are affect parents of 400,000 infants per year. They say 20% of new moms. That estimate we're assuming is actually underreported. So we're assuming that the numbers are actually much higher. And we do have strong evidence that that number is much, much higher with moms with low SES. So 33 to 50% of moms with low SES experience that. At a later point in our presentation, we're going to talk about COVID and what evidence do we have right now of COVID and PMAD numbers. But for now, this is the pre-pandemic PMADS numbers. Staggeringly, 50% of cases go unrecognized and untreated. You're going to see another slide coming up where actually they place that figure at closer to 75%. So if you think about this in the context of mental health across the spectrum, the fact that 50 to 75% of these families are struggling with an undiagnosed and untreated significant mental health complication is really astounding. As I said earlier, affects moms and dads. It's the number one most underdiagnosed obstetrical complication. And sometimes there's suicidal behavior. In rare instances, there's something called infanticide. We're not going to delve into that too much now, but if anyone has any questions about that, there's a lot of literature out there to dive deeper into that. Sorry, one sec. So again, emotional complications. Oh, so actually I didn't say this on this previous slide. Emotional complications are the most common complication of pregnancy. They can happen prenatal, they can happen postnatal. Some of the reasons why these happen, some of it is due to hormonal changes, right? Your body and your neurochemistry in your brain shift in pregnancy, and then they also shift postpartum, and they shift also if you're breastfeeding or chest feeding. Lack of sleep. That's a huge, huge, huge piece of this puzzle. And we're going to talk about that further when we get into some solutions for how to assist moms. Total change in lifestyle. I remember someone told me at some point, what happens from infancy until a child is 3 is absolutely miraculous, right? An infant, when they're born and they're sort of purely responsive and they just have the Moro reflex in those initial couple of weeks. In those short span of 3 years, an infant goes from being just responsive to being talking, thinking, feeling. Some 3-year-olds are potty trained. Some 3-year-olds know how to write letters, right? The 0 to 3 time period is absolutely incredible how many changes the brain undergoes in that time period. But aside from the 0 to 3 time period, the biggest shift that we will go through in our lives is going from being not parents to being parents. All of a sudden, from being independent people that are able to make decisions for themselves to all of a sudden having dependents that are completely take over and sort of dictate what your schedule is for those beginning couple of years. Right? There's a lot of relationship changes that happen. They said, another statistic is that 2/3 of couples report dissatisfaction with their marriage or relationship in the year following the birth of a child, right? There's a lot of relationship strain that happens in the postpartum period. There's bodily changes, of course. And then there's, mental health history and genetic predisposition, of course, are also playing a big piece in why PMADs happen. Within PMAD, so when we use that umbrella term, here are some examples of the different types of things that we're talking about. So we're talking about major depressive disorder. That's sort of the hallmark, when we always thought about postpartum depression, a lot of what we're thinking about is that major depressive disorder, right? Someone who has anhedonia, meaning they're not enjoying life. They might be crying and tearful. They might not want to get out of bed in the morning. They might not want to continue with some of the relationships that they've had, right? So we've got our major depression. We've got our bipolar disorder, which is a little bit different. It's the major depression plus episodes of mania, which can be someone, not sleeping, not eating, visions and ideas of grandeur. Then we have our anxiety disorders, and this is sort of going to be the meat of what we're talking about today. Then we have generalized anxiety disorder, which is a little bit different than the heading of anxiety disorders. We have obsessive compulsive disorder, panic disorder, and post-traumatic stress disorder. One thing, today the scope of our session is really on anxiety, but I'm sure that there is going to be years and years and years of conversations about PTSD and traumatic births during the pandemic. I think for so many families, their birthing experience, right? What that's like in the hospital. If you test positive and, for a while, hospitals were separating moms and babies immediately after if the mom tested positive. So, you test positive and your support system is not able to be with you. You're masked. Your nurse and obstetric team is all masked. You have fewer doctor's visits, no visitors, no partners, and being separated from the baby. I think we've sort of set ourselves up for a lot of trauma for birthing parents. We'll get into it. We'll get into it further in a little bit when we talk about COVID and PMADs, but these are absolutely unprecedented times for families Families are under tremendous stress from even thinking about, do I resume my fertility treatments or do I continue with my fertility treatments, to thinking about, oh, I think I might be pregnant, but can I even go to the store to get a COVID test? And then taking that pregnancy test and testing positive and then saying, uh-oh, do I now have to go into a doctor's office because now I've actually tested positive? And then do I have to go to another doctor's office for these follow-up appointments or for my ultrasound or once the baby's born for the checkup, right? I think every single milestone along the way from pre-pregnancy until early childhood is really different now in COVID times. It's really different and really significant. And we cannot underestimate the impacts that all of this is having on our moms, dads, partners right now. But we'll get into that more. All right. I did not want to reinvent the wheel, and the Maternal Mental Health Leadership Alliance created this fabulous resource. So I thought it was worth just putting it out there. It's probably hard to see on your screens, but all of the resources included here are cited at the bottom. But yeah, you can go and find this resource and use it yourself in your clinics or for your families. This highlights some of the things that we've already talked about, right? The 1 in 5 women will experience maternal mental health complications during pregnancy or the year following. 75% of the women with this will go untreated. As a side note, we're using the word women, but just so we know, there's also, this impacts moms and dads. This impacts gender non-binary people. This impacts transgender dads, right? So the term women is actually, we'll use that term for right now, but it's actually a lot more nuanced than just that. Other stuff here, it goes through depression or anxiety are 2 most common perinatal mood and anxiety disorders. And then at the bottom, it also talks about who are women at increased risk, right? So women living in poverty and women of color are more likely to experience maternal mental health conditions, and they are less likely to get help. I'm just going to say that again. Women of low SES and women of color are more likely to suffer from PMADs and less likely to get help, right? We're going to go through another slide on some of the reasons for why that might be, including lack of access to healthcare. I'm reading now from the bottom of this slide. Lack of access to healthcare, including culturally appropriate mental health care. This is a huge, huge problem in the maternal mental health world. Cultural and racial biases in the healthcare system, more barriers to care, such as lack of transportation or childcare, and fear or stigma around the implications of having a mental health condition. So this is another slide on specifically PMADs in the African American community. So the Icahn School of Medicine in Sinai found that 44% of African Americans reported depressive symptoms after delivery, compared to only 31% of white women. Again, we talk a little bit here. Some of the things that I added that weren't on that previous slide include racial trauma, right? I think right now, as we all know, there's multiple pandemics happening, right? And the racial pandemic is absolutely impacting families across the world, across the US, and definitely here in DC. Another study, 2011 study from Harvard Medical School and Harvard Pilgrim Healthcare, found that African Americans were less likely to receive care and had lower rates of follow-up and continuity of care. Right. So the continuity of care means, you go to a therapist and you do a couple of sessions. Great. But are you able to stay consistent and consistently work with that provider for the duration of the treatment course? Okay. Prenatal and postpartum anxiety. So we're going to talk about this a little more because, interestingly, I think for almost all of these, major depressive disorder, OCD, trauma, panic, all of these things look different in pregnant and postpartum moms than they do in the general population. Depression in a postpartum mom might look just like rage. It might not look like someone who's staying home, not getting out of bed, and crying all day. So depression, and that's for that holds true for all of the mood and anxiety disorders that we've discussed, right? These, the onset of symptoms, the severity of symptoms, the symptom presentation, how you treat these symptoms, every aspect of perinatal care is different and specialized and specific for moms in the prenatal and postpartum period, which is one of the reasons why it's really hard to find specialized care. It's hard to find specialized therapists. It's hard to find specialized psychiatrists. So that just, those are huge barriers to care, lack of specialized training. Okay, so what happens in prenatal and postpartum anxiety? How does this worry and anxiety manifest in the body? So it's interesting. So irritability, difficulty relaxing, sitting still, breathing, difficulty sleeping, difficulty concentrating, restlessness and frequent checking behaviors. That can also be related to the OCD. We'll get to that. Muscle tension, head, mouth, and shoulders. I started to say a second ago that it's really interesting, and I'm just going to continue that thought. It's really interesting because I will have patients come to me and they'll say, I'm feeling okay, but I'm really struggling to stay concentrated during my work meetings. I'm finding my mind just going everywhere, right? And that can be anxiety. It's not just, it might sound initially like ADHD, but actually that can be anxiety. So these are some anxious thoughts that moms might have. And these are what we call thinking traps. So these are sort of those unhelpful thinking styles that might make anxious moms are likely to experience. And one of the things that makes it really hard for them to manage that anxiety. So one of the things that we do in therapy, and one of the things that I specialize in as a cognitive behavioral therapist, is thinking through what are the specific cognitive thoughts that you're happening, what are the specific cognitive thoughts that you're having, and how can we challenge those, not prevent them? How can we challenge those so that those thoughts can be more helpful, right? So how can we challenge that to make an unhelpful thought a helpful thought? So different types of thinking traps listed here. All or nothing thinking, right? And that's, you took an exam and you got a 98 and you say to yourself, what happened to those other 2 points, right? If it wasn't perfect, then I failed, right? So that's all or nothing. Fortune telling, that's sort of this thinking of, this is what's going to happen in the future, right? So for a pregnant mom, fortune telling might be a mom who's only 3 months pregnant, who's saying, oh my gosh, I know I'm going to test positive for COVID and I'm not going to be able to hold my baby when my baby's born, right? So that fortune telling. Catastrophizing, that seems a little bit similar to fortune telling. That's when you look at any situation and you sort of think about the worst outcome. So it's not necessarily related to the future. It could be related to the present, but that's sort of saying right now, right? Me right now, Ruthie, in this given moment, my house is probably just going to come crashing down. Maybe there's a tornado in DC, right? The next one is personalizing, feeling like this relates to you. So, your mother or a friend didn't respond to your text. Oh, that must mean that she doesn't like me, right? Or, your OB appointment was delayed by 5 minutes. That must be because people are not aware of me and people are not caring about my time. Another thinking trap, the final one on this list, is emotional reasoning. And that's when you say something like, I'm feeling like that person doesn't like me or doesn't care about me, right? So rather than using the cognitive part of your brain, you're using the emotional part of your brain and saying, well, I feel this way. So these are all, there are others. These are just a couple of the main thinking traps that anxious moms can fall into. This slide is on so this is not COVID yet, where we haven't talked about the COVID yet. If you guys remember back to the initial slide where we went over the schedule, we were just going to do PMADs in general. So these are the anxious thoughts. The previous slide was on anxious thoughts for the general population. This slide is anxious thoughts specific to the perinatal population. Will my baby ever sleep again? That's a huge one, right? Really, really huge. I talk to moms all the time that just wonder, my baby was up 5 times last night. It's going to mean that when my baby is 6 years old, they're not going to sleep. And it means my kid's going to have insomnia in college and need to take Xanax every night to go to bed, right? There's a lot of different thinking distortions wrapped up in sleep. The other one, very common. If I go to sleep now, the baby's going to wake up in 5 minutes, so I should just stay awake. What's the point in sleeping, right? And this can happen a lot with new moms where they're awake and not sleeping and, just really not sure, if I sleep now and then the baby cries, then what was the point of that? I didn't need a 5-minute nap, but then if I don't sleep, will I ever get sleep again? So there's a lot tied into sleep. We're going to get to that in a little bit. This one, if I don't watch the baby, something bad will happen to her. So I should stay awake and watch. This I share when my oldest was born, even though I had already been a therapist working in this field for a while, my baby was born the first night in the hospital. For some reason, my husband and I just decided, we looked at each other and we're like, okay, it's your shift. And then we took turns staying awake all night, watching our sleeping baby to make sure she was okay, right? And I think it was by night 2, we had figured out that was not a healthy idea. But of course, there is a natural inclination after having 40 weeks of having, or of course, some people deliver earlier or later, right? But around having 9 months of your baby inside your tummy and well protected, and all of a sudden having your baby outside your tummy and wondering, is the baby cold? Is the baby hungry? Is the noise level okay? Is the baby wrapped warmly enough? Is the baby fed, right? Is the baby gassy? Is the baby's onesie uncomfortable, right? It makes perfect sense that after months of just walking around and keeping your baby safe inside of you, that all of a sudden having your baby outside of you would bring up and spark so many new anxious thoughts, right? I mean, to me, it seems perfectly reasonable. Okay, again, going down the list, is she breathing? Is she choking? Is she eating enough, right? Then there's the bigger questions. Will my life ever be the same? Will my relationship ever be the same? Will my body ever be the same? Will my partner and I ever get to, stay up late watching movies the way that we used to? Will our sex life be different, right? Last one is my baby getting enough milk? That's a huge one too. There is a lot of research on how breastfeeding versus formula feeding and chest feeding, how all of these different ways of feeding a baby can significantly impact mental health, right? So, there's some studies on how breastfeeding can be very protective with the extra release of oxytocin. But then there are other studies on how if there's a parent that really, really wants to breastfeed and is not able to, how that can also be a very big trigger for a PMAD. Okay, we're up to part 2, and I think we're right on time, which is great. Part 2 of this is thinking about COVID and mental health. So, just as a side note, or just to lay down the groundwork, I think these past couple of months since the pandemic began, a lot of the conversation was around health and how to keep people healthy and what are symptoms and how to prevent COVID. And I'm really happy to see that now the conversation is shifting to what we call the second wave of the pandemic, which is the mental health wave, right? So now it seems like the conversation is encompassing both the health and the mental health components to this. As we said earlier, every aspect of this, every single aspect of the pregnancy and the postpartum period is impacted by COVID. There's not, for the general public that's not pregnant or postpartum, there's many things that are different, right? And many things that are different and many things that are risk factors for mental health complications, which we'll discuss on this slide. But I think for pregnant and postpartum parents, it's happens to be one point where every single aspect of care and life is different because of the pandemic. We cannot underestimate how difficult and stressful and traumatic this is for our pregnant and postpartum moms, right? We really cannot, not pediatricians, not OBs, not providers, not schools. Everyone needs to be thinking about how can we support our moms right now, and dads and partners, right? Okay, so here's some of the reasons why. Here's some of the reasons why right now we're having this mental health wave during COVID, right? There's financial insecurity, of course, housing insecurity, right? A lot of people moving around and shifting around. Food insecurity. I think there was, I got a recent New York Times update on the number of kids that they imagine are going to suffer from food insecurity this year as compared with previous years. And it's astounding. There's isolation, right? That's a huge, huge, huge part of the prenatal and postpartum period. And what is an added stressor is this isolation piece. And we'll talk about that more in a minute. Lifestyle changes, right? Maybe you're not going to the grocery store as often as you used to. Maybe you're not exercising at your gym. You're not hanging out with your friends. You're not going into the office. Maybe you are going into the office and you're wearing tons of PPE. Maybe you are going into the office and your PPE doesn't feel sufficient, right? There's a lot of lifestyle changes. From a mental health standpoint, there are tremendous barriers in access to care currently. There's not, at least in the DC area, there are not that many providers that take insurance. The ones that take insurance are full. There are a lot of licensing restrictions. So even if you find the perfect provider for you, if that provider is not licensed in DC or not licensed where you are, that provider might not be able to render services. Every state has their own licensing laws. There's a lot of health anxiety. I see a lot of moms with health anxiety and OCD, specifically related to COVID. And there have been huge spikes in OCD and health and illness anxiety. There's loss, right? So there's absolutely the loss of family members, right? We know the numbers of people that we've lost to COVID is huge in this country and across the world. There's a lot of loss. And then there's also grief. There's grief related to, this wasn't the wedding I was supposed to have, or this wasn't the baby shower I was supposed to have, or this wasn't my retirement party that I was excited for, or this wasn't my retirement trip that I've been planning for 5 years, right? There's a lot of grief related to missed opportunities that due to COVID, people will be unable to experience. So COVID and PMADs. One study out of the University of Alberta, I noticed one study at the University of Alberta found that, and there are not many studies out currently, of course, because COVID is new and it's hard to look at perinatal women. There are a lot of different things that are there to protect perinatal women and children from being part of studies, which means that there is less research out there. But the study that we have right now that came out in June out of University of Alberta found that the pre-COVID anxiety rates were around 29%, and the COVID anxiety rates are more than double that at 72%. The pre-COVID depression rate was 15%, and this should say COVID depression rate. I apologize for that. The COVID depression rate is currently at 41%. Just to summarize what this slide means from that one, there's not many, but there are a few large scale studies out right now on COVID and perinatal mental health. But what this slide is telling us is that the anxiety rates are more than double and the depression rates are almost triple. That is huge. That is huge and incredibly significant. And one thing I had mentioned earlier, which maybe I'll just say a brief word about further, these rates we are expecting that this is underreporting, right? We are assuming that when people are going to their OBs or their pediatricians, wherever these research studies are taking place, that people, due to stigma or denial, or maybe someone else is in the room and they're uncomfortable for a variety of factors, we are assuming that these numbers are underreported, and actually the clinical rates are much higher than that. Okay, next slide. Again, ACOG, right? The American College of Obstetrics and Gynecology published another study in August 2020 saying, in summary, among pregnant women, more than half of the people that took this survey said that the psychological impact of COVID was severe, and 2/3 reported higher than normal anxiety levels. Again, severe, right? People reporting that their symptoms are severe and higher than normal anxiety levels. Here are some of the ways. So we've looked at this slide now. This slide is, what are anxious moms thinking? We've looked at this slide in the general population. We've looked at this slide in the perinatal population. And now this one is all around COVID and perinatal anxiety, right? So here are the things here are some of the thoughts that moms might be experiencing. If I leave my house, will I get COVID and make my baby sick? If my baby's sick, can I go to the pediatrician or will I get COVID? Can I go to my OB or will I get COVID? Right? Can I go to my ultrasound or will I get COVID? If I get COVID, will my partner or family be able to join me in the delivery room? We lost our jobs. How will we provide for our baby? We're not in our usual home. How will we keep our baby safe? If I get COVID, will I have to deliver in a mask? Right? And for some moms, sometimes you go to the hospital and it's 3 days before your baby's able to be delivered. And 3 days of delivering in a mask sounds really unpleasant. If I don't get to have a baby shower due to COVID, will my baby have everything they need? If I don't see people due to COVID, will my baby know their grandparents or aunts and uncles or friends or cousins? If I don't see people due to COVID, will my baby not have social skills? I hear this one a lot, right? As the mom of an infant, I know it's really hard not to have access. There's no libraries, there's no play dates, there's no play groups, there's no music classes, there's no playgrounds, right? There's a lot of places where normal infant and toddler social opportunities are not allowed to take place right now. If I don't see people due to COVID, will my friends ever get to know my baby, right? There's a feeling of this social piece. There's, bringing a baby into the world. Sometimes there's a baby shower. Sometimes once the baby's born, there are visitors. There's this whole aspect of it where there's this whole social aspect of it, right? Where people get to see your baby and hold your baby and say, oh, look at that baby's toes and look how cute. And oh, the baby has your eyes, right? Those micro moments, they seem small, but actually those moments are really, really important. They're really important for families to feel like they're seen and they're heard and that this milestone is being celebrated in a way. Who will care for my baby if I get COVID, right? And then there's, of course, like my baby's sneezing. What if it's COVID? My baby's sneezing. My baby's spitting up. My baby's rubbing their ears. What if it's COVID? My baby's poops don't look normal. What if it's COVID, right? There's a whole slew of anxieties related to the health of the baby and wondering, is the baby's health right now compromised because of COVID, right? So this is just a beginning. There's a lot more, as I'm saying this, I'm thinking about for families that have had other children with medical illness, wondering, what if this baby gets sick too, right? Or for parents or adults that have a family member with mental health or health issues, right? Wondering, well, what if this baby gets sick, right? So this is just a preliminary list. And of course, there's many, many more. So now we're to our third part, right? What do anxious mom needs? What do anxious moms need? How can we support them? So there's a whole range, right? So the first part is validation, letting these moms know this is so, so, so hard. This was never how it was supposed to be, right? This idea that it takes a village, right? It used to be, we thought raising a baby, it takes a village, right? You need to have your grandparents nearby and aunts and uncles and cousins and teachers and doctors and, neighbors, right? We are asking new families to do this all alone with no village, no visitors, no one bringing meals, no one helping do night shifts, no one coming in and, delivering baby goods or diapers or any of that stuff, right? There's this other idea you see on the slide, the fourth trimester. So the idea that you have 3 trimesters of pregnancy, and then the fourth trimester is this 12-week period where you're just acclimating to what does it mean now that I have this baby at home, right? How do I manage this? How do I manage the diapers? How do I manage my own needs? I haven't showered in 4 days, right? How do I balance what it means to have a baby home? So that's what we call the fourth trimester. In the past couple of years, there's a new term out there too, the fifth trimester, which we call like the back to work trimester, right? So if you go back to work, the fifth trimester is all about figuring out, how will I feed my baby when I'm gone? How will I make it home from work to pick up my baby? How will I manage my work demands at night if my baby's up all night, right? So this another transitional period, another trimester that takes time to figure out and get your feet underwater, get your feet on ground out of the water. Social supports, right? Anxious moms. Yes, people are in tremendous isolation right now, but we need to try to be creative and think of how we can support these families. So online groups, there's a number of different online groups. There's a number of them that are paying. There's a number of them that are free. There are a number of them like Postpartum Support International run specialized groups, right? So they run groups specifically for African-American moms. They run groups specifically for moms that have had a baby in the NICU. They run groups for moms that have had a prior pregnancy loss, right? So there are a lot of specialized groups. What you can do if you are a family member or you are a pediatrician or you are an OB, instead of telling a mom, go find an online group, find that group for her, right? And say, hey, do you have anything on your calendar Tuesday nights at 7:30? Postpartum Support International has this group. Here's the link, right? Whatever we can do to make that to eliminate those barriers, whatever we can do to bring the resources to the moms will be tremendously helpful, right? Phone calls, texting, FaceTime, do all those things, way more than you're comfortable with, right? Sleep. This is a huge one. We've talked about this in our slides around how is this time period just anxiety provoking? This is a huge one, right? So even if you get 15 hours of sleep, if all of that sleep is just in the form of cat naps, right? So 1 hour here, 2 hours there, 2.5 hours here, 45 minutes here, that is not restorative sleep. We know you need to have consecutive hours of sleep, ideally 4 or 5 hours, in order to actually feel like you've received restorative sleep. Usually for people, the most important time that you can get that sleep is the first chunk in the nighttime, right? So if you're a partner and you have a mom at home who's feeling really anxious or tired, you can say to her, you know what, I'm going to do the first shift. I'll take the baby from 8 until 1. You go sleep. And then from 1 onwards, I'll sleep and that person takes over. But making sure that moms get that 4 or 5 hours, and ideally We want their big chunk to be at the earliest part of the night if possible. Right? So partners or parents can come help. There's postpartum doulas. I know that there's some, especially in DC, we have a couple of amazing postpartum doula agencies. We have a couple of amazing doula agencies that also support moms during labor and delivery. These postpartum doula agencies, some of them are taking extreme precautions, so they're able to help despite COVID, which can be hugely beneficial for moms. Healthy lifestyle. That's a really important one, right? Nutrition, exercise, drinking water. I had a mom recently that said she was hospitalized for dehydration because caring for her infant, she forgot to drink water for I don't know how long, but long enough that she required hospitalization for that, right? So if you're a partner or you're a family member, some of the things you can do is say, let's keep a bag of almonds in every room in the house. So anytime you're hungry, you can grab some almonds. Or if you're leaving the house, you say, before I leave the house, can I make you a peanut butter sandwich, right? Making sure that whatever we can do to take the job out of it, however we can simplify matters, that will be hugely helpful, right? Even something like, I'm going to put the diaper on the changing table so that it's ready for you next time you need it. Right? Like anything that we can do to make life easier. I'm going to make you a smoothie and I'm just going to leave it by your bedside. Right? It's really, really hard for moms to wake up, to think, let alone to do things like prioritize exercise or nutrition. Right? When I say exercise here, I'm not implying, run a marathon, not even running. Maybe it's just a 15-minute walk. Exercise, the truth is that from a mental health standpoint, rigorous exercise, and I think it's supposed to be at least 30 minutes multiple times a week, rigorous exercise has been shown to be incredibly effective for depression and anxiety. So moderate exercise is definitely excellent from a mental health standpoint, but sometimes possibly unrealistic for a new mom, right? So maybe it's do 15 minutes of stretching your back or a YouTube yoga video while you can. This is a topic for another conversation, but I've even heard there's even like breastfeeding yoga. So you can do yoga in a different position and breastfeed your baby simultaneously. Talk about multitasking, right? Cognitive strategies, right? So as a therapist, there are a lot of different cognitive strategies that we can use to help moms with these anxious thoughts. But also saying, what's within my control, what's not within my control, right? You planning ahead 3 months down the line, what if I catch COVID in 3 months from now? Not within your control, right? You saying my delivery date is in 2 weeks from now. Should I eat at that indoor restaurant? Definitely within your control, right? So some things are within your control that can help. Some things are not within your control. Of course, if you have any concerns, talk to an OB, a pediatrician, or another therapist. This is another amazing slide another amazing resource that I love. This is done through the DC Collaborative for Mental Health in Pediatric Primary Care. It's available on the DC Health Check website. And, on the front page, it talks about some changes that you can make at home. But the reason why I really love it is the back page is an actual behavior activation plan, right? So one of the things that we know from a mental health standpoint is we're not going to wait until you're in crisis mode to start planning what do you need to get help, right? Once you're deep down in that hole, it's much harder to dig your way up than it is to put preventative practices into place to prevent you from falling down that hole to begin with. So my maternal well-being plan, I use this often, almost all the time. It's a really, really helpful tool because it tells you things like, who do I go to for help when I need it, right? What are some ways that I can connect with other people? What are my own early signs that I'm feeling bad or anxious, right? This says, put your therapist number on here, right? So that in that moment, and we hope you never have to, right? We hope no one ever has to use any of these crisis resources. But in that moment, if you are really struggling, you don't have to think. All you have to do is pick up your piece of paper and see, what's my plan? I already wrote this down. What are my strategies, right? Here's the number. This also lists the number for WIC, right? If you're a family experiencing food insecurity, it lists 911, suicide prevention hotline, right? Really helpful resources here. This next worksheet, also not designed by me, you can see on the bottom where it came from. This is called the COVID Coper in Pregnancy, right? And this tells moms to do things like observe your body, right? Calm, thinking of breathing techniques. There is a lot of research on the impacts of mindfulness and meditation and mental health. Absolutely, unequivocally, right? Those can be really helpful. I will say they can also be really hard, right? It's not easy for someone with anxiety or a postpartum mom who has 9 million things to do. It's not easy for that mom to say, okay, I'm going to take 5 minutes and just sit here and focus on my breathing and focus on, my body and how is my body feeling, right? Definitely helpful, but also really hard. But let's look at some of the other things we have here. We have prepare, remember, right? Soon you'll meet your baby and become a family, right? So these are all strategies during pregnancy. Pause, right? Take a stock of the miracle that's your body and your baby. One thing we didn't talk about too much, but just a side note is, the impacts on your body, right? For a lot of people, you spend many, many years getting comfortable with what does your body look like, right? And maybe sometimes you're less comfortable with it. Sometimes you're more comfortable with it, but you have many years of adapting and figuring out what is my body and who am I as a person, really? And then all of a sudden, in pregnancy, in a really, really short period of time, in less than 1 year, your body morphs completely. Not only do you have a watermelon on your belly, your shoe sizes change, your hands change, your eyes change, your gums change, your hips change, your ribs can change, right? Almost every physical aspect of your body changes. And it's the same thing, not just your body, it's the same thing with your mind, right? If you have a baby at 35, you had 34 years to figure out, who am I as a person? What are the things that I like to do? How do I spend my time? How do I motivate myself to get up and out of bed in the morning? And then all of a sudden, you go into the hospital, you deliver a baby, and you've got however long you're in the hospital until you get home, right? So 48 hours to figure out, who am I as a parent, right? And of course, when the fetus is in you, you're also a parent. And of course, that whole time in the hospital, you're a parent as well. But meaning you had 35 years to figure out who are you as a person, and then just a matter of months or just a matter of days to figure out, who am I as a parent? That is an incredibly vulnerable new identity to wear. I think that's one of the reasons why it's really hard for postpartum families to make relationships, social relationships, because of that added level of vulnerability. Okay, similar to the one that we just had, but of course this is for postpartum. And then we have our resources section, right? So here I'm happy to send this to anybody if anybody has any questions, but these are some books that I found to be particularly helpful. Listed here, Penny Simkin and Karen Kleiman are sort of two of the leaders in perinatal health and mental health. These are all some apps. So the first couple of apps are therapy apps that I find really helpful. Then there's some breathing apps, and then there's some just general perinatal educational apps. And then lastly, a couple of different websites that I love. So DC Perinatal Mental Health in DC, we are amazingly fortunate. There's a consortium, a group of us in the DMV area that all specialize in perinatal mental health. And we work together and we attend advanced trainings. Postpartum Support International does amazing work. postpartumprogress.com. You can still access some resources on that site, Postpartum Stress Center, and Marseille Society. And that is it for my presentation. And now I think we're open for Q&A. Just waiting for the host there to help us with that Q&A. I'll stop my screen share. Okay, let me see. Sorry, there's a message here in the chat. Okay, great. How can we identify if it's an anxiety, irritability disorder, or if it's just mood changes due to the fluctuation of the hormones, which is normal in pregnant women? Great question. I think that the answer to that is, if you have any questions, if it's just not seeming right, then you should consult a professional, right? Pediatricians, OBs should be able to assist you with that. The slides that one of the initial slides that we went over went through a little bit of those different symptoms, but we're not expecting the audience to be able to, we're not expecting, I don't know if that person was a mental health professional or not, but we're sort of not expecting partners to necessarily be able to differentiate if this is a normal postpartum response or this is actually a mood disorder. So if you have any questions, please see our provider. Are there any insights on the mental health and COVID impact for preemie parents in the NICU? Yes. We don't have a lot of research out of it. What we know about preemie parents so far, those numbers that we looked at about trauma and anxiety and depression are incredibly magnified for preemie parents. I think I assume as a mental health therapist that 100% of families that are in the NICU are experiencing some form of trauma or anxiety. Absolutely, during the times of COVID, that is magnified. Absolutely. I don't know that we have any research out on that right now, of course, because COVID is new and research takes time, but undoubtedly. How do you help get people past the stigma of therapy so they can get the help they need? Great question. Really, really difficult. I think some of the things that we do, one of the things that we've talked about in the DC area is integrating the mental health conversation in all aspects of care, of medical care, right? So when you come in for your 6-year-old's checkup and the doctor says, do you have any medical issues? And you say, yeah, my kid has a stomach ache. You're also going to say, and my kid gets anxious about XYZ, right? And the doctors, so we want the parents to be the ones to be forthcoming about that, but we also want the doctors to be asking about that, right? So the doctors to be saying, how is the child sleeping at night? How are they feeling? What are stressful situations for that child? Right. So we really want this mental health conversation to be happening among families and among providers at every level. So when you come in for your OB appointment and your doctor says, how are you feeling? Are your feet swollen? And how are your moods? And how are you sleeping? And have you noticed yourself to be a little bit more irritable? Right. We want everyone to be asking those questions. Okay. What can we do to actively support the mental health of our babies as they grow up? Great question. I think there's a complicated, I don't know if that question is for COVID or just in general. To answer that previous question that we talked about, reducing the stigma, I think it's the same thing with mental health with kids, right? Talking about things. I'm a firm believer that you talk about everything, right? Like your kid is scared about his fish dying, talk about it. Your kid, you have there's COVID out there. I know so many parents, their natural inclination is there's a pandemic out there. We're going to shield our kids from this. So we're not going to talk about it. And that makes sense. That protective urge makes sense, but it's not helpful for kids. It's not. There's a lot of research on avoidance and how avoidance actually increases anxiety, right? Kids know this isn't normal. So if we don't talk to them about it, they're coming up with all sorts of ideas in their head, So we need to be open with them and honest with them. Of course, we need to be developmentally appropriate, right? You're not going to tell a 3-year-old, oh, this is COVID and this is what an ICU is and this is how you intubate a person, right? Absolutely not. But you could say things like, I watched a video called all about the yucky bug, and the yucky bug is here and we have to protect ourselves from it. So we wear masks and we stay inside and we wash our hands a lot, right? So developmentally appropriate, but have those conversations. Next question. Chest feeding is a new term for me. Am I understanding it correctly as feeding the baby from a bottle chest to chest? No. Good question. Chest feeding is what had normally been thought of as breastfeeding, where you're putting your breast and feeding the baby on a breast. Chest feeding is for transgender or gender non-binary folk who don't want to use the term breast. They would rather use the term chest, right? So it could be a dad, so maybe a trans person, a transgender identified person that is breastfeeding their baby and prefers the term chest feeding to breastfeeding. Where can I find them? My maternal well-being plan you shared. So that's available on dchealthcheck.net. So dchealthcheck.net has a number of amazing resources. And you can actually even just Google that and Google, my maternal well-being plan. There might be a way as well. I think I can ask the AV squad here to send out some of those resources or send something out after. Or there might be a way for you to contact me too, if that wasn't clear. These are really great questions, guys. Any others? Okay, wonderful. Well, wait and see if any others come in. I'm happy to answer them. It was really a pleasure. This is a little bit bizarre because I only see myself in the screen. I don't see any little faces in the Zoom box. But it was really a pleasure to talk to you guys about this further. Thank you for being engaged and caring and for working hard to support our families. They need it now more than ever. So thank you for doing your part. Have a great day. Bye.
Just the name itself, I really like it. Jubilee Jumpstart, like you're jumpstarting your kids to a great future. I really enjoyed the name.
Come on, everybody.
It's like a community. It's like a family here. When I brought my kids here, I said this will be a place where I will probably keep my kids here for a long time. I'm a student. I'm a single parent. I'm striving to get my degree, and that is a goal that I'm setting in place for myself, and I'm going to get there. I have 2 kids here. My oldest, Cedric, he's been here since he was 5 months. He's now 4. My youngest, Sydney, she has been here since she was 5 months as well, and she is now 22 months. I mean, I struggle like a lot of other parents, but a lot of my difficulties and struggles that I've had since my kids been here, staff have seen it and they've asked, do you need the help? What can we do to help you? And that right there is something that's big for me.
enrollment means everybody is starting their Jubilee Jumpstart journey. Children go into their classrooms, and we almost immediately are talking to parents about their opportunities for engagement, connection, and growth themselves.
There's different parenting groups you can do. To have a group that you can connect with and be open with and share, it was great. We shared different parenting styles, parenting techniques, and that's what helped me.
Jubilee Jumpstart was founded to address the opportunity and achievement gap. We see in our city and our country that children with less opportunity achieve less, and that is generational. So when we want children to get on a path of lifelong learning, they are supported in that by the people around them also participating in lifelong learning.
When he started here in Jubilee Jump, his mind changing like 100%. They helped me to be a better mother, good person, extra good person. Jubilee helped me to feel more comfort about my person, understanding to my son. They helped me a lot.
When you teach at this age, they grasp things like, well, they're sponges. It's just amazing seeing him like grow. Like he loves to teach other people things. He'll show other people things. And it's amazing. And the teachers, I credit the teachers a lot. They are amazing teachers.
Jubilee Jumpstart is a special place for me because they gave me so much. Courage, wisdom. It was life-changing.
We learn in community and in relationship. And so our little place is a place where community is built, really family is built, that changes the trajectory. Children can do anything if they are given the right launching pad for it.
We don't just own anybody, we welcome whoever comes in, and we give everybody the opportunity to be here.
Nobody seems to get kicked to the side or the curb. If you see someone that's struggling, hey, you need some help? Let me help you. That's the type of community this is. That's the type of center this is. They're there for me.
To those people who help this center, the only I can say is thank you. God bless those guys who donate those money. Thank you. Thank you, thank you, thank you.
There is a major crisis with America's health system. Millions of people, including many with health insurance, are unable to get the care they need. The solution is simple. Having access to reliable, high-quality healthcare is the way to keep people and communities healthy.
That is why 30 years ago, we created Mary Center, because we believe that everyone should have access to the best possible healthcare, regardless of their ability to pay. For us, quality care is not a service. It's a human right.
For Mary Center, quality care goes beyond just medical care. It includes access to the very best in dental, behavioral health services, low-cost pharmaceuticals, education, and social services. We believe healthy people make healthier communities. So we've decided to refresh our look to show that by connecting each person to the best possible care, we will not only improve lives, but we will strengthen communities too, one person at a time. When Mary Center puts care at the core, you can too. To schedule an appointment or find out how you can help, visit our centers or go online at maryscenter.org.
This is a vaccination to keep you healthy. You don't want the measles, do you? Here's your sticker.
Protect your loved ones and they'll pass it on. Don't let COVID-19 stop you from protecting your child.
You're next, Mr. Bear. You need a flu shot.
Now more than ever, it's important your child receives their vaccines on time. Brought to you by the District of Columbia, Department of Health.
All good. See, it wasn't that bad.
Do you worry your preschooler doesn't walk, talk, draw, or play like other children their age? The Early Stages Center can help. Our friendly staff will assess your child's development through one-on-one, play-based activities. Early Stages will then connect your family with the educational services that are right for you. Everything is free, whether your child is in public school, private school, or are not yet enrolled in school. Call 202-698-8037, a service of the DC Public Schools.
This is a total no judgment zone. We don't want parents to feel like because of X decision that they've made that they've done something the wrong way, because I know how sometimes difficult it is to manage diet and brushing. So it's important to put families at ease, encourage instead of discouraging, and making sure that they know that we are partners in their care, and not those that are there just to wag a finger or judge them about anything that they're doing. To get a call from a parent that says, I can now breastfeed my child because of you. Maybe they've been told elsewhere they'll never breastfeed their kid, and a simple procedure to do something now changes that whole trajectory for them. Or a child that may have been referred to me and no one can do anything with them, and they come in and I'm going, really? The kid walked in and out smiling, like we had a ball. And we didn't have to do anything like sedation or general anesthesia, which we do pretty often, for them. We didn't even have to do that. A simple, just encouraging, it's gonna be okay, we've got this, we're gonna do it together, let me know what you need. Just kind of thinking about families and thinking about my own family as we make decisions within our practice.
Listen, every day in America, workers are forced to make the unthinkable choice between caring for themselves and loved ones or keeping their job. You know how that can be. Beginning July 1st, 2020, workers in the District of Columbia will be eligible for paid family leave. That's right. When your loved ones need you most, you should be able to step up to the plate and take care of them. That's why DC Paid Family Leave will provide up to 8 weeks of parental leave to bond with a new child, 6 weeks of family leave to care for a sick family member, and 2 weeks of medical leave to care for yourself when facing a serious health condition. Hey, we understand that sometimes life happens, and you shouldn't have to choose between your livelihood and your loved ones. So if you want to learn more about DC Paid Family Leave, check it out at dcpaidfamilyleave.dc.gov.
Complete the 2020 U.S. Census. It is safe and secure. It benefits your city, your community, and your family. When you fill it out, you will help determine where billions of dollars will go, funding our kids' education, school breakfasts and lunches, healthcare and Medicaid for our seniors, better social services, creating more affordable housing, job training, and helping everyone have access to food. Complete the census online, over the phone, or once you receive it in the mail. You matter. Get counted. 2020census.gov.
We've been able to really shift our care according to what we feel like the population needs. I think one of the things that makes us strong is that we provide culturally aware care. I think it helps that the majority of our midwives are of color. When we're talking about birth disparities, especially with African American women, I think that we are now entertaining the conversation about years of generational distrust with a lot of healthcare systems. And so I think that we create a safe space for that interaction, not only by having more staff of color, but also just things like our late policy. Midwives, we see our patients regardless if they're late. We see pregnant patients late and we see babies late.
Our whole family is just tied up into community of hope.
Hi, I'm Heidi Murkoff, author of What to Expect When You're Expecting, and you may have heard moms matter to me a lot. That's why I founded the What to Expect Project and why I'm here to support Mayor Bowser's National Maternal and Infant Health Summit, because every mom should matter. I always say motherhood is the ultimate sisterhood, that no matter where she lives, her cultural, socioeconomic, political profile, the color of her skin, every mom shares a common goal. Every mom wants the best for herself and her baby. But far too many moms, especially Black moms, don't receive the quality, respectful prenatal care they need and deserve. Too many Black moms die of complications of pregnancy and childbirth, and far too many of those deaths are preventable. And the onset of COVID-19 has increased the risk for Black moms. Gaps are widening as clinics and hospitals in rural and urban areas close, and care becomes even less accessible, and more of our most vulnerable moms I speak to every day, are falling through the cracks of care. The truth is we can take care of our moms and control pandemic at the same time. We just have to pick our healthcare priorities, and we have to stop always putting Black moms last, like they don't even matter. One way we can do that by voting. This year, whattoexpect.com, a home to over 19.6 million moms, and the What to Expect Project have launched #MomTheVote to urge moms to speak up and be heard, to vote for those who vote for them, for maternal health care that doesn't discriminate or come with a use-by date, and that isn't paused because of a pandemic, for paid family leave that allows moms to care for themselves and their babies instead of forcing them back to work after only a week or two, affordable childcare, and so many other policies that impact their lives and their children's futures and that of their mom sisters. There's no better investment in our future than the health and well-being of our moms. All of our moms, no exceptions, no disparities. Let's stop failing our moms. Let's make moms the priority they should be.
I'm Polly Donaldson, Director of DC's Department.
Dual pandemics. The impact of systemic racism and COVID-19 on breastfeeding. Hosted by the District of Columbia Breastfeeding Coalition.
Good afternoon, and thank you for joining our panel. I'm Dr. Sahira Long. I'm a pediatrician and medical director for the Children's National Anacostia Facility, and also a member of the Mayor's Lactation Commission, a lactation consultant, and a wife and mother of two. Before we get started, I'd like to thank the organizers of this summit for inviting our panel to participate, our panelists for agreeing to participate, and the board of the DC Breastfeeding Coalition that I'm president of that helped us to organize the panel, and especially Aubrey Villalobos, who helped us prepare everything for today. So before we get started, I'm going to invite our panelists to introduce themselves, and then we'll jump right in. So Dr. Asiadu, can you introduce yourself, please?
Hi, good morning or good afternoon, depending on where you are today. My name is Dr. Ifeanyi Asiadu. I am an assistant professor at UCSF, the University of California, San Francisco, and I am happy to be here with you all today and just want to thank the DC Breastfeeding Coalition for the invitation. Thank you.
Thank you. And Dr. Buck? You're muted.
Good afternoon, good morning. I'm Dr. Kimmery Bugg with Reaching Our Sisters Everywhere, Rose. We are located in the Atlanta, Georgia area. We are a national organization that was designed to address breastfeeding disparities in the African American community. And I am also grateful for the opportunity to be here and share with you today.
Thank you. And Mrs. Henderson.
Good morning, good afternoon. My name is Rashawn Henderson. I am a certified lactation counselor and work as a breastfeeding peer counselor at Children's WIC in Washington, D.C. And I also thank you for the invitation to be here today.
Thank you. All right, so before we start, none of our panelists has anything unfortunately financial to disclose, and we will not be discussing anything unapproved. I think we're all biased in our passion for breastfeeding, which is the topic of this panel. So as a pediatrician, I can't do a set of slides without objectives. So this is what we hope that you will take away from this presentation today. And I'm gonna start this off with a story just so we can center this discussion and understand why it's important. So this is based on a true story. And I want you to meet TK, who is a 32-year-old first-time mom, first-time pregnant, married African-American female. She tested positive for COVID-19 upon arrival to the hospital for delivery. And at that point, she was told that her husband, who was in the car, could not stay with her as she gave birth to their first child in spite of having had a negative COVID-19 test and a few days prior to their arrival. Her birth plan for as few interventions as possible was switched to a plan that to receive an epidural after she found out she'd have to give birth alone. Mind you, her husband was in the car outside the hospital. The epidural further slowed down her contractions, and ultimately she delivered by C-section. So TK gave birth, and after doing so, she was allowed to hold her daughter skin to skin and then given two options. She could either keep her daughter with her, and her daughter would stay in the room with her the whole time she was in the hospital, but she should keep the baby 6 feet away at all times and shouldn't hold her unless she was breastfeeding after wiping her chest down and washing her hands. And the other option was to let the hospital team take the baby to the nursery, and she wouldn't see her again until it was time for discharge. So think of that story as we dive in. So we, at the Children's National Anacostia site, I serve as the medical director for our lactation support center, and TK's mom, so not TK herself, but the grandmom of the baby with whom I work, reached out to see if our team could help her with breastfeeding, because after 24 hours of life, mom still had not seen a lactation consultant, even though she'd asked to see one. And then on the last morning prior to her being discharged from the hospital, she was offered a telehealth lactation consult by one of the inpatient lactation consultants at the hospital, since they weren't seeing COVID-19 positive moms. So think about that as your first experience with breastfeeding as we dive into our presentation. So first, I'm going to start off with some basic information, and then I'm going to invite our panelists to join with some questions. So first, why does this even matter? So this is information based on a meta-analysis done by the Association for Healthcare Research and Quality. And what they showed pretty clearly is there's definitely a risk for not breastfeeding. So the greatest risk, of course, are for children and infants, which, you know, this is a maternal and infant health summit, so we know that that's why it's important for this summit. But for our babies, we're seeing an excessive risk of 257% for hospitalizations in the first year of life for babies who weren't breastfed. And in case you thought breastfeeding was only good for the mom, the risks listed on the bottom are the risks that are excessive for mothers that don't breastfeed. So moms who don't breastfeed have a higher chance of developing maternal ovarian cancer and also breast cancer. And there's also cardiovascular risks that are higher for moms who don't breastfeed. So Lancet put out a series of breastfeeding journal articles a few years back and showed that we could, with optimal breastfeeding, we could prevent 20,000 breast cancer deaths worldwide. So what exactly is optimal breastfeeding? The two sources of, somebody said they can't see slides. Two sources of information for what we consider optimal breastfeeding are the World Health Organization, which recommends breastfeeding continue until exclusively for the first 6 months and then continue until at least 2 years of life. And then the American Academy of Pediatrics sets their own recommendations, which agree that moms should breastfeed for at least the first 6 months exclusively and continue to breastfeed for at least 12 months or as long as is mutually desired by the mom and the baby. So based on these recommendations, the U.S. Surgeon General's developed goals for breastfeeding. So Healthy People 2030 goals came out in August, and the two goals for breastfeeding that were set were, one, to increase the proportion of infants who are breastfed exclusively through 6 months of age, and to increase the proportion of infants who are breastfed at all through the first year of life. And you can see, based on the baseline from 2015 births, that we have quite a ways to go to reach our 2030 targets. And how do we do for reaching the 2020 target? So this is a slide that just shows how the United States did compared to DC, compared to the Healthy People 2020 targets. And this is data from the Centers for Disease Control and Prevention National Immunization Survey. And you can see for DC and the United States, we looked pretty good with quite a few of these breastfeeding behaviors. The goal that we did not meet was breastfeeding up until a year. So we're doing okay as a nation and DC as a whole with reaching any breastfeeding goals and exclusive breastfeeding goals until you look at duration. And on the outside, that looks really good. But if you break it down and look at how we're doing as a nation by race, this slide shows that there are huge disparities. And if you dig really deep, you can see that the only two races and ethnicities that did not meet any of the Healthy People 2020 goals were non-Hispanic Blacks and non-Hispanic Native Americans and American Indians and Alaska Natives. And the moms who did meet Healthy People 2020 goals meet all of the Healthy People 2020 goals were non-Hispanic white and non-Hispanic Asians. All right, and so that was the DC, that was the nation. So how does DC stack up? Unfortunately, the CDC does not put out rates by race on an annual basis. So the most recent information we have is based on 2009 to 2011 births. That's the last time we had a cohort done on breastfeeding race by race. And you can see DC looks a lot like the nation. There's a difference between who's actually meeting the goals in DC. So even though we look like we're meeting it on a whole, if you break it down, there's really a tale of 2 or 3 cities here. And so I'm going to switch gears really quick and talk a bit about what breastfeeding recommendations look like during the COVID-19 pandemic. So the 3 major health organizations put out recommendations starting back in March as we were trying to figure out what was happening with the COVID-19 pandemic. And from the beginning, the World Health Organization has pretty much stayed consistent with their guidance. The recommendations that the World Health Organization puts out for the world, so for the global community, is that mothers with suspected or confirmed COVID-19 should not be separated from their infants. And if they are suspected to have or confirmed to have COVID-19, they should still be encouraged to initiate and continue breastfeeding, because from what we know, mothers that should be counseled that the benefits of breastfeeding substantially outweigh the risk of possible transmission. And so they do recommend that a mom that is confirmed or suspected to have COVID-19 take a few precautions when they're breastfeeding. So they recommend that nothing change in terms of early skin to skin and contact between the mom and the baby as soon as possible after birth. If the baby is ill, the baby needs to have arrangements to stay safe in the neonatal intensive care unit, and the mom should be allowed to have free access to the unit with appropriate infection control precautions. If mom desires to breastfeed, the mom should perform frequent hand hygiene with soap and water or an alcohol-based hand rub, especially before contact with her child. If she's having respiratory symptoms, she should sneeze or cough into a tissue and immediately dispose of it, and then perform hand hygiene and wear a medical mask until symptoms resolve or she's no longer considered under the need to be isolated. If she's been coughing on her chest, she should clean her chest with soap and water before breastfeeding. But if she has not been doing this, there's no need for her to wash her breast prior to every breastfeeding session. So the CDC, as of September 4th, agreed that the ideal setting for the care of a healthy term newborn is within the mother's room. So separation is not a requirement. Temporary separation should be considered to reduce spread to the infant, and the risks and benefits of temporary separation should be discussed with the mother and her healthcare team. Any decision made should be respectful of the mother's wishes, and if she does choose to perform temporary separation, she should be encouraged to express breast milk, and a healthy caregiver who is not at high risk for severe illness should bottle feed the newborn the expressed breast milk. If she does not choose to separate, then she should take precautions, just like the World Health Organization recommended, to avoid spreading the virus to the newborn, including washing her hands, wearing a mask, and when she's within 6 feet of the baby, and as much as possible, maintaining a physical separation from the baby when she's not feeding. This information is taken straight from the CDC's website, so I'm not going to belabor the point, but this is the guidance that moms who are interested in breastfeeding would see if they went to CDC and pulled it up. And then the last source of recommendations is the American Academy of Pediatrics, who pretty much when the pandemic started, there was no information upon which to base recommendations. So all of these organizations did the best they could with the available information and have continued to update the recommendations as more information becomes available. So this information that I'm displaying right now is updated as of July 22nd, which, the pandemic started in March. So this is the third iteration of guidance from the American Academy of Pediatrics. And it's pretty much now aligned with the recommendations from CDC and the World Health Organization. The AAP strongly supports breastfeeding as the best choice of infant feeding. There have been several studies that are really small that have detected nucleic acid in the breast milk of COVID-19 positive moms. But what we don't know is whether or not that virus is actually infectious or if the mom is providing protection against the baby getting COVID like she does with a lot of other viral infections. Given all this information, there's no reason that mothers should not be counseled to breastfeed, and they should do exactly what the CDC recommends: perform hand hygiene before breastfeeding and wear a mask during feeding. All right, so with that said, I'm gonna jump into a few questions for Dr. Asiadu. And so Dr. Asiadu, can you share with us information about the impact of systemic racism, looking at the breastfeeding rates by race across the United States? Can you share with us some information about how systemic racism and institutional racism have played a role in these disparities, and any policy or system solutions that we know work?
There we go. Hello, everyone. Thank you so much, Dr. Long, for your presentation and for a very critical and important question. So I'm, again, very appreciative of the DC Breastfeeding Coalition for the invitation to discuss racism, bias, and breastfeeding, chest feeding, and donor human milk with you all today. And so let's dive right in. Next slide, please. So before I get started, I wanted to acknowledge that I am coming to you all from the Bay Area, and really wanted to acknowledge the Bay Area's indigenous peoples and communities, and let you know that I'm presenting from stolen land of the Ohlone tribe here in the Bay Area. Next slide, please. And in regard to objectives, I definitely want to talk with you all in regard to the significance of systemic racism and bias as it pertains to breastfeeding, chest feeding, and the use of donor human milk, in addition to policies and system solutions and resources. And then, of course, happy to answer any questions that you all may have. Next slide, please. So I have 15 minutes with you all today. So if you don't take anything away from our time together, I would love for you to take away these 3 key points from my presentation: that racism and bias are major barriers to Black families reaching their infant feeding goals. And again, that can be breastfeeding, chest feeding, and the use of donor human milk, but also milk sharing and also supplementation and formula use and things of that nature. I also want you to know that Black women and birthing people do breastfeed, chest feed, and use donor human milk. And also that policies and system solutions, such as baby-friendly hospital initiative, are key to improving infant feeding disparities and inequities. And so you'll hear me go back and forth in regard to using infant feeding versus breastfeeding, chest feeding, the use of donor human milk. Infant feeding is a more inclusive term, because I know, and we all know, that every family, every individual may have different infant feeding goals. And so, but primarily I'm going to be speaking about breastfeeding and the use of donor human milk for this presentation. Next slide, please. So when we're talking about racism, specifically, we're talking about the systemic, institutional, and structural type of racism. We're talking about the discriminatory policies and practices, whether they're informal or formal, that are embedded in our everyday work, embedded in our systems. We're talking about the macro level systems, social forces, institutions, ideologies, and processes that interact with one another to really generate and reinforce inequities among racial and ethnic groups. And these definitions can be found in Dr. Kamara Jones, the Gardener's Tale paper. And I think it's also important to note, as Dr. Long presented, the different disparities and inequities that we see in breastfeeding that have been noted for over 40 years since we've been capturing data, that the disparities do not occur in a vacuum, right? We have to acknowledge and identify the systemic barriers and challenges preventing individuals and families from meeting their breastfeeding goals, especially given that if we look at breastfeeding intention rates, we see that Black women, we see that Indigenous folks, we see that Black Indigenous people of color want to breastfeed. They want to be able to provide human milk for their infants. But we have to think more critically in regard to what systemic structural barriers are impacting the way in which individuals and families can actually operationalize those goals. Next slide, please. So again, while we know that there are lower breastfeeding rates in Black and Indigenous communities, we also know that Black women and birthing people want to breastfeed. So when we're thinking about these disparities, we also have to note that there are barriers as it pertains to who receives breastfeeding education and resources. We know, unfortunately, that Black women are less likely, I should take that back. We know that in-hospital healthcare providers are less likely to discuss breastfeeding options and services with Black women. And we know that maternity care practices that are supportive of breastfeeding are limited in communities with higher Black populations. We also know from a study conducted by Dr. McKinney and her colleagues in Chicago that Black infants were 9 times more likely to be offered formula immediately after birth. And another study conducted by Dr. Sergeson and her colleagues at the California Perinatal Quality Care Collaborative at Stanford noted that infants in the NICU receive desperate care and were less likely to have access to donor human milk. And so we cannot say or continue to discuss inequities and disparities without context. And we can't use race as the reason why or the issue or the response or the answer to why these barriers exist. We know that these disparities and inequities exist because of racism, because of bias. Race, it isn't that race or because someone self-identifies as Black, that puts them at greater risk for poor access to services and care and desperate care and things of that nature. It's the lifelong exposure to racism that impacts one's ability to meet their infant feeding goals, that impacts their ability to have positive perinatal health outcomes, both for the birthing person and infant. So that's something that we really need to shift in terms of our narrative. Next slide, please. And I'm just going to shift gears a bit. Next slide. To touch on the policies and system solutions in regard to, so we know that these disparities and inequities exist. What can we do? First and foremost, we need to listen to Black women and birthing people, right? We need to understand their lived experiences. And when folks are reaching out for assistance or help or support or resources, we need to be open to hearing thoughts, hearing requests, but also providing the necessary education and resources that are needed. We need to engage in anti-racism and bias training. And I know that this is a touchy topic right now, especially if you work in government, whether that's at a federal level, at a state level. So I have a lot more thoughts on that, but I will just say that in order to address the inequities and disparities that are impacting our Black Indigenous people of color, we have to talk head on about the racist policies and practices that are impacting their healthcare, that are impacting their quality of life and the quality of care being received. And we also need to talk about the importance of diversifying healthcare, the healthcare workforce. And specifically here, as we're talking about breastfeeding and lactation, we know that the IBCLC, when we think about the breastfeeding and lactation workforce, we often think about IBCLC's International Board Certified Lactation Consultants. However, we know that those who self-identify as Black, Indigenous people of color experience great barriers to achieving that certification, and that we see more diversity as it pertains to our breastfeeding peer counselors, our certified lactation educators and counselors. And so we really need to take a step back and address what are some of those systemic barriers and policies and practices that are impacting the trajectory of lactation support persons in achieving the IBCLC certification? In regard to other ways in which we can address infant feeding disparities and inequities is really utilizing evidence-based practices and policies, and specifically thinking about the baby-friendly hospital initiative, which I'll talk about in a few minutes in more detail, but also the importance of peer-to-peer support and really investing in community-led initiatives. And when I think about peer-to-peer support, I think about WIC and breastfeeding peer counselors, but I also think of organizations such as ROSE. And we're really fortunate to have Dr. Bug on this panel today, who's the CEO of ROSE, to talk more about the work that they're doing to increase peer-to-peer support and really are leading really amazing community-led initiatives. Next slide, please. So I wanted to talk just a little bit in regard to the Baby-Friendly Hospital Initiative. For those of you who may not know, it's a global effort geared towards improving the role of maternity care services that enable birthing and lactating individuals to breastfeed or chest feed. It really aims at improving access to maternity care practices that are supportive of breastfeeding and is in accordance with the International Code for Marketing Breast Milk and Substitutes. Every hospital that obtains the baby-friendly designation moves that much closer to meeting important public health goals and increasing the proportion of live births that occur in facilities that are really supportive of this public health initiative in terms of breastfeeding. We know that it isn't, when folks usually think about baby-friendly, they think about that it's more of a local initiative or it's a local practice, and really it's a global initiative that was created by the World Health Organization and UNICEF in 1999, and it's a really broad scale implementation of 10 steps to successful breastfeeding, and I'll go over quickly those 10 steps. Next slide, please. And so these are the 10 steps, and I won't go over each of the 10 steps, but there's a essential group of different policies and practices that are incorporated within a hospital's culture and practice. The Baby-Friendly Hospital Initiative isn't only about practice change, it's really about culture change as well, where you have to have a policy. There's staff training and education and competencies that need to occur. We can only think about breastfeeding support and resources as it pertains to the postpartum unit and after someone gives birth. We really need to think about what type of education and resources are being provided during the pregnancy. And then also when someone is in our hospital setting, what type of resources and supports are we providing during labor or after they give birth? Are we providing immediate skin-to-skin, barring any medical complications or any issues? Are we providing lactation support and care and resources? As Dr. Long presented in her case study, the patient in question didn't have access to a lactation consultant or someone to really assist in providing lactation support in the early hours and days after giving birth. And we know how critical that is. Do we have connections to community-based resources and supports? We know that individuals, barring again any type of medical complications, will spend only a few days in the hospital laboring and giving birth, but they will spend majority of their time within their communities. And so really thinking about how are we providing information and resources to really sustain breastfeeding and chest feeding or the use of donor human milk after someone is discharged. Next slide, please. The Baby-Friendly Hospital Initiative, it's a pathway which hospitals and health systems engage in over a period of years. This isn't something that can happen overnight. It takes a great deal of time, investment in resources, collaboration of not only in-hospital, but outpatient and community-based organizations to really come together to ensure that a hospital is designated baby-friendly. And it's a very rigorous process, and the designation is good for 5 years with the redesignation process afterwards. Next slide, please. So again, just thinking about why baby-friendly, we know that hospitals play a really critical role as it pertains to breastfeeding and chest feeding initiation, duration, and exclusivity. We know that evidence-based maternity policies and practices supportive of breastfeeding really impact the initiation, duration, and exclusivity rates that Dr. Long shared in her opening slides. And there's also data that shows that baby-friendly hospital designation really improves exclusive breastfeeding rates. And we see that extensively as it pertains to hospitals and communities, regardless of race, ethnicity, and socioeconomic status. And so if we're really thinking about policies and practices to address racism and bias and to improve disparities and inequities, baby-friendly hospital is definitely, will definitely help lead us in the right direction. Next slide, please. So I just really quickly in my last few minutes with you all wanted to share just the impact of baby-friendly here in California. Next slide, please. In addition to knowing the importance and significance of baby-friendly, here in California, we took it a step further. Following the 2011 Surgeon General's call to action, one of the recommendations in that call to action was the acceleration implementation of baby-friendly in the United States. In 2013, Senate Bill 402 was proposed and signed into law here in California that all birthing hospitals and birth centers needed to adopt the baby-friendly 10 steps or an equivalent practice, which we call the model hospital policies, by 2025. And so we are all in as it pertains to really wanting to provide the most evidence-based maternity care practice, knowing the impact for both the birthing person and the infant across their life course. Next slide, please. As you can see over time, the proportion of infants born in baby-friendly hospitals has risen in California from 14% in 2010 to approximately 45% in 2018. Next slide. And something that I had asked my colleagues at the state in the California Department of Public Health, a maternal, child, and adolescent health branch to look at as it pertains to our data is really wanting to see what impact had our efforts in regard to baby-friendly designation, what kind of impact has that had on our disparities or inequities in regard to where individuals giving birth. And so as you can see from this data that was pulled in 2017, 2018, we definitely need to run a new analysis. We see that Black women are more likely now to give birth in baby-friendly hospitals in California. That wasn't the case at the beginning of our work. We were seeing baby-friendly being implemented in more affluent communities and hospitals and health systems. However, with a concerted effort and a collective push led by the California Breastfeeding Coalition, in addition to our collaborators in WIC and our local breastfeeding coalitions, we've definitely seen improvements in who has access to baby-friendly hospitals. Next slide, please. We also have eliminated the gap between individuals and families on Medi-Cal, and for those of you outside of California, Medicaid, and those who have employer-based insurance. Again, thinking through inequities and thinking through where baby-friendly hospitals were first being implemented, this is a real significance for us because that shows that regardless of insurer type, that birthing people and families will have access to baby-friendly hospitals, policies and practices going forward. And I will say, though, that just because an institution or hospital is baby-friendly designated does not necessarily mean that there still isn't work to be done, right? There's still definitely work that has to happen on a continuous basis to address anti-racism and bias practices. Next slide. And as you can see, we know that not all women and birthing people in California have equal access to maternity care practices that are supportive of breastfeeding. So even though while California has the highest number of baby-friendly hospitals in the US, we know that we still have a great deal of work to do, as you can see with the geographical gaps in regard to where baby-friendly hospitals are located. Next slide. And so I just want to share a few resources with you all in regard to the Baby Friendly Hospital Initiative. In the United States, Baby Friendly USA is the designating organization here in the US. So if you have any questions or thinking about your hospital or birth center or thinking about going baby friendly, definitely check out the Baby Friendly USA website. And I also just wanted to lift up different organizations across the country that are doing amazing work as it pertains to supporting, promoting, and raising awareness around the importance of the Baby Friendly Hospital Initiative. We have Rose, who works in collaboration with CHAMPS. We have the Carolina Global Breastfeeding Initiative based out of UNC, and also the California Breastfeeding Coalition, which I'm the immediate past board chair of. Baby Friendly Hospital Initiative was a huge priority for us and continues to be going forward. So if you have any questions or are looking for resources for your communities, definitely check out these organizations. Next slide. So then, and last, there are definitely other ways in where you can identify community resources, specifically around state, local breastfeeding coalitions, cultural coalitions, definitely your local hospitals and clinics and professional organizations as well. Next slide. And this is a quote from the Baby Friendly USA website, which I absolutely love. And it reads, "Baby Friendly designation is hard for a reason. It's hard to ensure that mothers and babies all over the country receive the highest standards of infant feeding care in the precious first days of the child's life." And if we're really wanting to think about health equity, breastfeeding equity, ultimately eliminating health disparities and inequities, we really need to be thinking about ways in which we're providing the highest standards, evidence-based practices that will impact maternal and infant health across the life course. And last slide. Again, my key points. We know that racism and bias are major barriers to Black families reaching their infant feeding goals. We know that Black women and birthing people want and do breastfeed, chest feed, and use donor human milk. And we know that there are policies and practices and system solutions, such as the Baby Friendly Hospital Initiative, that can be used and utilized to really improve key, not only infant feeding disparities, but also maternal health disparities, such as maternal mortality and morbidity as well. And then the last slide is just thank you for this opportunity. And feel free to email me if you have additional questions, or check out my research lab's website for more information about the work that we do. Thank you so much.
Ingrid, thank you, Dr. Asiadu. We're going to save all questions that have come in so far until the end of the presentation, and hopefully we'll have time for them at the end. So I hope you can stay on in case there are questions for you. All right, so now I'm going to invite Dr. Bug to share a little bit of information about how we in the healthcare and community can help support people of color to reach their breastfeeding goals. And if you're
Thank you all. Just want to say that more than most women and birthing people in the United States breastfeed their babies. We've for the first time, reached the Healthy People 2020 goal of more than 81% of the nation's birthing people and mothers breastfeeding. So we are excited about that. Next slide. However, the disparities are here, and the gap has been, so as everyone has already mentioned, since we started taking statistics. So we want to make sure our goal right now is to close that gap. And next slide, please. We've talked quite a bit about COVID, which is extremely important in these days right now. And I'm going to talk a little more about it in telehealth because we've had that covered very well. Next slide. Uprisings that are going on in the country are another issue right now that is deterring and causing a cause of some moms not being able to reach their breastfeeding goals. We need to know, and you know, it's been pretty apparent in these days that racism makes us sick. There are things that we can do to address this, and there have been some phenomenal programs and projects that are going on due to COVID, due to the uprising, that have truly helped to address these concerns in breastfeeding. Next slide. This is a hospital in the Atlanta area that is baby friendly. We are extremely excited to say that, but this was the day of white coats for Black Lives Matter. And these are medical schools from Emory University and Morehouse School of Medicine and Mercer School of Medicine, all pretty much together, stating that they truly understand and want to address these disparities. Next slide, please. So wanted to talk briefly about emergency preparedness because here in the Georgia, Alabama, Louisiana areas, we are having tornadoes and hurricanes. And in California, they're having all of the fires. Climate change is real and it's affecting a large majority of the country. And because of this, of course, we're having many concerns with breastfeeding also. So just a couple of things that we need to address to make sure that folks head to safety. Keep offering the breast. That's important. Learn how to hand express. Store milk if possible. Delay weaning. Milk sharing is a thing that is going on. We don't have time to talk about it now, but it is something that is definitely going on, and think positive. Next slide. So I want to just briefly talk about peers, partners, policies, and programs. And a lot of this has definitely been covered, and I'm happy about that. Next slide. So peers are phenomenal. They're really changing the landscape of breastfeeding. We need to assure that we have lactation support providers at every level in order to make sure that moms are able to reach their breastfeeding goals. It's phenomenal to have someone next door or down the street or at the local recreation center or your place of worship that can help young women with breastfeeding in the community, for us, by us. Next slide, please. Partners are very vital. Particularly Black men feel a lot of times that they're invisible in the entire process. We need to make sure that we address the partners, make sure that they are part of the process and have the opportunity to learn. We say a lot of times that our families are resource deprived. They have not been given the information and the resources to make informed choices. So that needs to be done for the mothers, for the fathers. Next slide, please. And also for grandmothers. Grandmothers are a needed resource for breastfeeding sustainability. And therefore, we need to assure that they are brought into the process when possible and are also given the resources. Next slide. So we've talked about the baby-friendly process, which has truly made an amazing difference in communities of color. It's not necessarily that all boats, the tide raises all the boats, because sometimes folks don't have a boat, but policies definitely do change some behaviors, and we're happy that more and more hospitals are on the baby-friendly pathway. Next slide, please. So telehealth, this is something that I need to just share with you right now. There are some phenomenal programs going on. The CARES Act is funding telehealth projects through UNC Chapel Hill, which is one that Rose is involved with. And we are able to give funds to people throughout the 10 public health regions to address telehealth needs. Our funds, specifically Rose, are going specifically to support providers who are in the community. So doulas, midwives, lactation counselors, CLCs, and we are really happy that these funds will allow them to spend more time doing telehealth. And also we have funds for the communities to sort of address the digital divide. So look forward to sharing more information about that. Next slide. So the reality is some communities start in the hole. Some communities start at a place of privilege. And it is important that we address these concerns and make sure that the moms get the resources and information that they need to be successful with their breastfeeding goals. Next slide. Couple of references. And that is it.
Thank you, Dr. Bug. I had to unmute myself. As always, a pleasure hearing you. And I'm going to shift our conversation to the DC WIC program. And I have a question for you, Mrs. Henderson. So can you tell us how this COVID-19 pandemic has impacted WIC's ability to provide breastfeeding supportive services, and what you all are able to do to support families that choose to breastfeed at this time?
Thank you, Dr. Long. Next slide. So because of COVID-19, it has made a significant impact on how we provide breastfeeding services. We've had to alter how we provide breastfeeding education and also breastfeeding support because we are not seeing our participants in person. So because of that, we are unable to provide one-on-one lactation support, offer hands-on breastfeeding assistance to our moms who may be having some difficulties with latching or positioning. We are unable to conduct in-person breastfeeding classes, and also we aren't able to lead in-person breastfeeding support groups. Next slide, please. But we have been able to provide remote services. So we have been able to have one-on-one lactation support, appointments and breastfeeding classes, support groups, all via Zoom. And in addition, we've actually been able to hold a breastfeeding event. As you all know, last month was breastfeeding, National Breastfeeding Month. And so within my agency, we were actually able to hold two events, one highlighting National Breastfeeding Week and also Black Breastfeeding Week through Zoom. Through this, we've also been able to continue calling our participants, calling and following up through their pregnancy and also through their breastfeeding journey. We've been able to continue also offering BFED, which is a text messaging program that we offer to our participants, where the breastfeeding peer counselors are able to reach out to our participants, especially if we are unable to reach them by phone. But also this program provides general breastfeeding information to a participant during her pregnancy and also during her breastfeeding journey. And in addition, we also have a partnership with the Pacify app, which also gives our participants 24-hour access to breastfeeding support from a lactation consultant. And with this also being said, they're able to download this app for free because we're able to give them a special code to download it and sign up for free. Next slide, please. Also, we're able to give resources. And I just wanted to highlight two resources here. We have the USDA WIC breastfeeding support website. And the goal of this website is to equip WIC moms with information, resources, and to support them so they can be successful in their breastfeeding journey. One thing that I love about this website, which Dr. Bug kind of spoke a bit on, is that they actually have a section just for grandparents and also fathers, and how they can support mom through her breastfeeding journey. Then also we have the DC WIC website here. This is another place where mom can find out what services we provide within WIC, or see a schedule when we have our support groups, depending on what agency the participant may go to. Then also we have a list of other organizations within the area that mom can be able to check out and see. Next slide. So just like I said, we've had to become creative with how we reach our moms during this time, since we are not seeing them in person. So one of those ways that we try to become creative and think outside the box is we went to our social media. We went to DC WIC's Instagram page. And so during the week of Black Breastfeeding Week, we highlighted our breastfeeding peer counselors. So each day a breastfeeding peer counselor was highlighted, and she was able to basically share a little bit about her breastfeeding story or experience, and also her experience as a breastfeeding peer counselor. We also were able to highlight the Million Milk March event that the DC Breastfeeding Coalition and BSARS that they hosted, and that they were graciously invited WIC WIC participants to join in for free to join the event. And one thing I did not put on the slide, but I also want to highlight one agency who actually highlighted their own participants on their actual Instagram page as well. Next slide, please. So with that all being said, and how we have changed how we reach our participants, and how we've been able to educate them with remote services and support them with remote services, we've actually seen an increase to our rates. Since the end of March, where we started remote services, we've seen an increase. And now these rates consist of our moms who are exclusively breastfeeding, who of course are not getting any formula from us, moms who are mostly breastfeeding, so moms who are mostly breastfeeding and receiving a little bit of formula from us, and then our moms who are partially breastfeeding, who may be doing half and half, or maybe doing a little bit more formula feeding than breastfeeding. And it's been amazing just to see our rates increase and see that what we're doing is working, because we all know how important we know how important what we are doing and how much it's needed. Next slide. Thank you.
Thank you, Mrs. Henderson. We have a few questions. I'm going to stop sharing slides and open up so we can answer some questions. And this was great. Dr. Asiadu, your presentation reminded me of all the work that we're doing in DC, trying to achieve what California's been doing. And I trust and believe that the work that we're doing will close those gaps. So there have been a few questions that have come in, and I'm going to take them in order. We have about 5 minutes before our panel ends. Anyone can answer any of the questions. So first is, are there general tips or guidance for how a mom can advocate in regards to breastfeeding, particularly in a hospital? Anyone can jump in. Go ahead, Dr. Burke.
So yes, I'd like to say, first of all, they need to ask for some help. If their physician writes an order for them to be seen, it is more likely that they will. So then ask everybody that comes in. The nurses are trained to manage normal lactation, and therefore they should have the skill to be able to help them. And then, just continue to ask for what they need. That is what is most important, is to verbalize and say, this is what I need. Everyone has the opportunity to evaluate the hospital and the staff. Everybody's looking for, those patient satisfaction surveys. So be sure to tell everyone that you plan to fill one out, and then ask for what you need.
Thank you, Dr. Bug. Anyone else have anything else to add?
I would echo that. And I think, too, unfortunately, in the era of COVID, folks may not have a number of people in the hospital room with them. But if they are able to have a support person, that person as well can advocate and say, my partner, my daughter, my whomever needs support, and do that as well. And I think, too, also thinking about before someone gets to the hospital, there's a lot of those type of questions in terms of what are the resources available at the hospital, who can I go to, things of that nature that folks can look into during their pregnancy, to some of that anticipatory guidance to better prepare for when they do get to the hospital setting.
Thank you. And I don't really have much to add to that wonderful answer. And in the interest of time, I'm going to skip to the next question. And this will be quick. I'll answer it. Is there evidence-based data to support the CDC's recommendation that encourages continued breastfeeding during the COVID-19 pandemic by race? So I'm not completely sure what that question is asking. Is there evidence base for the recommendation to continue breastfeeding? Absolutely. There's no evidence that the virus has been found in the milk to cause infection. The jury is still reaching verdicts on how protective it is, but like most other viruses, we think it's going to be the same. In terms of by race, the CDC collects data on births by race nationally every year, and it's usually released in August. So the data that I shared at the beginning of this talk was based on births from 2017. And so I'm not sure that we'll have data on births by race for this time until 3 years down the road. So it'll be interesting to see what happens with those rates as we get them. It's a retrospective survey that gets sent out after the babies reach the end of their breastfeeding experience. There's a specific question for Dr. Asiadu. Do you know specific examples of anti-racism and bias trainings that have had significant positive effects in the healthcare field? Oh, we can't hear you. Maybe our time is up.
Sorry, hello?
Oh, yes, now we
now
can hear you.
Okay, sorry about that. Dr. Joya Pericari's group with INBEC, they do amazing anti-racism and bias trainings nationally. The diversity group that was just recently started by Dr. Rachel Hardiman out of the University of Minnesota School of Public Health, they also host really amazing anti-bias and anti-racism training. Also, Race Forward and the Center for Social Inclusion also have really amazing evidence-based type trainings and approaches that are available as well.
Thank you so much. And it looks like we're at time. So I want to, again, thank our panelists for this amazing talk, and again, our organizers for allowing us to share this information. There were a couple of questions that really one question that we didn't have time to get to, and we'll find out if there's a way to share that answer on the app.
There's a major crisis with America's health system. Millions of people, including many with health insurance, are unable to get the care they need. The solution is simple: having access to reliable, high-quality healthcare is the way to keep people and communities healthy.
That is why 30 years ago, we created Mary Center, because we believe that everyone should have access to the best possible health care, regardless of their ability to pay. For us, quality care is not a service. It's a human right.
For Mary Center, quality care goes beyond just medical care. It includes access to the very best in dental, behavioral health services, low-cost pharmaceuticals, education, and social services. We believe healthy people make healthier communities. So we've decided to refresh our look to show that by connecting each person to the best possible care, we will not only improve lives, but we will strengthen communities too, one person at a time. When Mary Center puts care at the core, you can too. To schedule an appointment or find out how you can help, visit our centers or go online at marycenter.org.
This is a vaccination to keep you healthy. You don't want the measles, do you? Here's your sticker.
Protect your loved ones and they'll pass it on. Don't let COVID-19 stop you from protecting your child.
You're next, Mr. Bear. You need a flu shot.
Now more than ever, it's important your child receives their vaccines on time.
Brought to you by the District of Columbia Department of Health.
All good. See, it wasn't that bad.
Do you worry your preschooler doesn't walk, talk, draw, or play like other children their age? The Early Stages Center can help. Our friendly staff will assess your child's development through one-on-one, play-based activities. Early Stages will then connect your family with the educational services that are right for you. Everything is free, whether your child is in public school, private school, or not yet enrolled in school. Call 202-698-8037, a service of the DC Public Schools.
This is a total no judgment zone. We don't want parents to feel like because of X decision that they've made that they've done something the wrong way, because I know how sometimes difficult it is to manage diet and brushing. So it's important to put families at ease, encourage instead of discouraging, and making sure that they know that we are partners in their care, and not those that are there just to wag a finger or judge them about anything that they're doing. To get a call from a parent that says, I can now breastfeed my child because of you. Maybe they've been told elsewhere they'll never breastfeed their kid, and a simple procedure to do something now changes that whole trajectory for them. Or a child that may have been referred to me and no one can do anything with them, and they come in and I'm going, really? The kid walked in and out smiling, like we had a ball. And we didn't have to do anything like sedation or general anesthesia, which we do pretty often, for them. We didn't even have to do that. A simple, just encouraging, it's gonna be okay, we've got this, we're gonna do it together, let me know what you need. Just kind of thinking about families and thinking about my own family as we make decisions within our practice.
Listen, every day in America, workers are forced to make the unthinkable choice between caring for themselves and loved ones or keeping their job. You know how that can be. Beginning July 1st, 2020, workers in the District of Columbia will be eligible for paid family leave. That's right. When your loved ones need you most, you should be able to step up to the plate and take care of them. That's why DC Paid Family Leave will provide up to 8 weeks of parental leave to bond with a new child, 6 weeks of family leave to care for a sick family member, and 2 weeks of medical leave to care for yourself when facing a serious health condition. Hey, we understand that sometimes life happens, and you shouldn't have to choose between your livelihood and your loved ones. So if you want to learn more about DC Paid Family Leave, check it out at dcpaidfamilyleave.dc.gov.
Complete the 2020 U.S. Census. It is safe and secure. It benefits your city, your community, and your family. When you fill it out, you will help determine where billions of dollars will go, funding our kids' education, school breakfast and lunches, healthcare and Medicaid for our seniors, better social services, creating more affordable housing, job training, and helping everyone have access to food. Complete the census online, over the phone, or once you receive it in the mail. You matter. Get counted. 2020census.gov.
Is we've been able to really shift our care according to what we feel like the population needs. I think one of the things that makes us strong is that we provide culturally aware care. I think it helps that the majority of our midwives are of color. When we're talking about birth disparities, especially with African American women, I think that we are now entertaining the conversation about years of generational distrust with a lot of healthcare systems. And so I think that we create a safe space for that interaction, not only by having more staff of color, but also just things like our late policy. Midwives, we see our patients regardless if they're late. We see pregnant patients late and we see babies late.
Our whole family is just tied up into community of hope.
Hi, I'm Heidi Murkoff, author of What to Expect When You're Expecting, and you may have heard moms matter to me a lot. That's why I founded the What to Expect project and why I'm here to support Mayor Bowser's National Maternal and Infant Health Summit, because every mom should matter. I always say motherhood is the ultimate sisterhood, that no matter where she lives, her cultural, socioeconomic, political profile, the color of her skin, every mom shares a common goal. Every mom wants the best for herself and her baby. But far too many moms, especially Black moms, don't receive the quality, respectful prenatal care they need and deserve. Too many Black moms die of complications of pregnancy and childbirth, and far too many of those deaths are preventable. And the onset of COVID-19 has increased the risk for Black moms. Gaps are widening as clinics and hospitals in rural and urban areas close, and care becomes even less accessible. And more of our most vulnerable moms I speak to every day, are falling through the cracks of care. The truth is we can take care of our moms and control pandemic at the same time. We just have to pick our healthcare priorities, and we have to stop always putting Black moms last, like they don't even matter. One way we can do that by voting. This year, WhatToExpect.com, a home to over 19.6 million moms, and the What to Expect Project have launched #MomTheVote to urge moms to speak up and be heard, to vote for those who vote for them, for maternal health care that doesn't discriminate or come with a use-by date, and that isn't paused because of a pandemic, for paid family leave that allows moms to care for themselves and their babies instead of forcing them back to work after only a week or two, affordable childcare, and so many other policies that impact their lives and their children's futures. and that of their mom sisters. There's no better investment in our future than the health and well-being of our moms, all of our moms, no exceptions, no disparities. Let's stop failing our moms. Let's make moms the priority they should be.
I'm Polly Donaldson, Director of DC's Department of Housing and Community Development, and I wanted to talk about affordable housing in the District of Columbia and our affordability crisis. The rule of thumb is you should only spend about a third of your income on your housing needs. We know we have to do more in the District of Columbia.
Mayor Bowser has been a national leader in affordable housing policies and funding, but she realizes we need to do more. So she challenged the city to produce 36,000 housing units by 2025, with 12,000 affordable to low-income residents. Our first analysis is looking at where affordable housing is across the city and where it should be in the future. This summer, we asked residents to examine a map of affordable housing in the city.
I feel the distribution of affordable housing in the city could be a lot better. It seems too much of it is concentrated east of the river in Ward 7 and 8, and not enough of it in Ward 3. Ward 3 would be a perfect place to have more affordable housing. It's resource rich.
For me, housing and affordable housing is personal. I first got involved in producing affordable housing for our homeless families over 30 years ago. To me, it's all about who is your neighbor, and are we able to say that anybody who wants to be in the district, whether you've been here for 5 generations or for 5 minutes, there is a place for you in the District of Columbia.
Clara is our first child, and we didn't know what to expect being first-time parents. And it's just been such a fun experience to watch her grow. Starting out very early, we monitored Clara's development using the Learn the Signs Act Early checklist. It was just an amazing resource to be able to say, okay, this is what she should be doing at this age. And it calmed our fears a little bit.
I would have to say my favorite resource of the Learn the Signs Act Early would be the app. But having the app readily available has honestly been great. And it's been awesome just seeing her development and growth. The Learn the Signs Act Early app is actually very easy to use. I can access it right there on my phone. And whenever my mind kind of pops to it, I can open it up.
I think I am a Learn the Signs Act Early super user. The Learn the Signs Act Early materials have been invaluable to me because I feel like they've been there with me throughout parenthood in kind of the way that a wise old friend might be.
Using Learn the Signs Act Early has helped me monitor my daughter's development and gives me a great peace of mind that the information is accurate and it's backed by science. It's fun to see when she achieves a milestone. I feel very proud for her and excited.
And it's not just a milestone of, is my child doing this next thing? It's what should I be working with my child next? Because that can be a big question mark as a first-time parent.
I want to know if maybe she's lagging farther behind than she really should, and that's something to bring up with our pediatrician.
Having something at my fingertips to kind of go through it with her physician. She's hitting these milestones, but not these other milestones. Should I be concerned? What kinds of things can I do to bring her up to speed? And then taking that and translating it with her teachers in her classroom to make sure these are the things I would like to focus on, and how can we work together to make sure that she's developing appropriately.
The Learn the Signs Act Early resources empower parents to take a stake in tracking their child's developmental milestones.
Holding Space for the Future of Black Birth, hosted by Thomasina Oliver.
Okay, go, Tom.
Okay, great. Hi, we are the panel speaking about holding space for the future of Black birth. I'm Thomasina Oliver. I am a certified professional midwife. I've delivered a lot of babies, and I am an advocate for women being able to choose how to birth, where to birth, and related to disparities. I felt passionate about being present today to speak about birth and maternal and infant well-being and what it looks like in the future with all that's going on. And I am happy to be here and excited to answer any questions. And thank you for having me.
I'm Saul Corbin. I am the training coordinator for Friendship Place, which is a nonprofit in DC that's trying to end homelessness. I am an educational psychologist and very passionate about the role of fathers in child care and child rearing. And so I will be speaking on that today. Thank you.
Hello, I'm so happy to be here. My name is Bree Mobley. I am a holistic doula and founder of Birthright Wellness, LLC. We're located in Baltimore, but serving Black families and mamas in the DMV and beyond. I am a self-care advocate as well as a Black life, Black birth advocate. So I'm super excited to share my knowledge and experience in the work today.
Hi, my name is Wilona Finley. I am very excited and grateful to be here. Thank you for having me. I am a licensed professional counselor in the state of Virginia. I am the owner of New Pathways Counseling Services, and I am also a crisis clinician at a local community mental health clinic. I am also a student midwife. I am passionate about mental health. I'm passionate about holistic health. I'm passionate about Black birth. And I'm passionate about dismantling systemic racism.
So one of the things that I was excited to do was to come on and talk about midwifery. I've been a midwife for a very long time, and we're looking at over 20 years. And when I know and heard and learned of Wilona being a midwife student, I was very excited about that because we do not have enough Black midwives. And the more, the merrier. It would be great in the future of Black birth to see community midwives of color, Black midwives serving their communities, educated and prepared as traditional and ancestral midwives, not just from the book knowledge, but of being allowed to freely use the intuition that we carry within us to serve our communities. And that's one part of what I would like to play a part in and continue to play a part in and see myself being active in, and would love to solicit when we do the Q&A, any questions related to becoming a midwife and or serving in the communities of color and for people who definitely are aware of what's going on with Black birth and Black maternal health. So that's what I wanted to say there.
Okay, so I guess that's my cue to go. Thanks, Tommy. So I really want to talk today about how communication can break down between Black parents after a newborn. We know that it's a beautiful thing to occur, but that definitely changes the dynamic of the relationship. And I think that Black fathers need a lot of support and encouragement, information, confidence, tools, whatever, to just stay engaged and help them be as involved as they possibly can with the new family. Some of the stressors that a new baby brings to the dynamic, of course, is that Responsibilities change dramatically. So time is severely limited. Exhaustion is maximized. So people are tired. They don't have as much time to give to each other or the relationship. Of course, the baby becomes priority. So everything gets compromised, which means that it's a direct threat to their intimacy. So I'm just going to offer some tips that I think would help in this very limited time that I have. I'll try to be as brief as possible. Well, one thing that a lot of people find hard to accept is just scheduling, but is another way of saying time management. It's so important with the newborn and just kind of knowing what the new rules are and when things are supposed to happen. And that means everything from known feedings to changing to breaks that are needed, time together even. And even intimacy. So one of the first things to go, unfortunately, in relationships is that the partners stop dating each other. They get settled, they get complacent. And all of these things have to be enhanced and encouraged during this time where, again, the focus of the energy comes is on the newborn, which takes away from the relationship. So yeah, don't stop doing the things that you used to do that brought you together in the first place, right? And you have to schedule time for that. Get a babysitter. There's babysitting co-ops in neighborhoods now where shared babysitting or sometimes shared parenting. So parents will schedule time to watch other kids so they can go out on a date or do something together. Giving each other alone time too. So everybody needs a break, right? Newborns are 24/7 responsibility. So, but everybody needs a break, especially the mom, right? So scheduling time for that, where the father can step in and just have care on his own for a little bit. All that, of course, encourages bonding with the newborn, which we know is one of the things that we struggle with in our community, right? As far as the men being empowered in this time where they a lot of times feel disempowered, talk to their brothers, talk to their boys, talk to other men that have had newborns and babies and kids, and find out their perspective and how they navigated that dynamic. Because effective communication is very, very important now. Effective communication is defined as when your audience, in this case your partner, receives the message as you intended it. So it's going to require a step up of communication and just saying, but checking in to make sure that your partner got it the way that you meant it. And if you don't do that, then there are a lot of assumptions that are made. Oh, I heard you, I heard what you said, but then the interpretation is left up to whatever. And that's where some problems can arise. So checking in to make sure that the person heard it the way that you meant it. Also work on active listening. Now this is tough because I'm asking both parents to step up with the sharing of their needs, the sharing of their feelings, which a lot of us are uncomfortable doing, particularly Black men, but also listening for those needs as well. This is probably the most difficult challenge, I think, to communication with newborns and Black families. But got to open up your mouth more than know when to close it, and then open up your ears. Also learning your partner's love language, right? We all communicate our care and concern for others differently. And some of us are verbal, some of us are touchy-feely, whatever. Knowing how your partner communicates that. And just a quick example, men often will communicate their love and concern by what they do as opposed to what they say. And so what we need to do is start listening for that differently. Instead of always relying or wanting the words, maybe listening to other ways in that he's showing his love, or the partner is expressing their love. So, last but not least, just learning how to compromise, right? I mean, now it's no longer a situation of two that you have to compromise, navigate, but three. So keeping that flexibility in working with your partner. And look, I'm real too. Look, if it ain't working, get some help. I don't care who it's from. Get calling in the pastor, a good friend, a coach, a professional license. So I don't care who it is, as long as they're objective and sane, bring in an outside voice to help you with your journey. Thank you for letting me share. I'll pass it on to Bree.
Hello again, everyone. My name is Bree, and there are a few things that I really want to talk about in reference to my beliefs as far as the future of Black birth. I've had my own disparities in my own birth, which really led me to fall into this work. And so you have to, in my experience, I give thanks for my birth trauma, because otherwise I wouldn't have found my true passion, which is holistic doula work. And so I would say in this work, I've been able to heal myself throughout my own experience in birth, and I love to tell moms and birthing people that if you wouldn't go into a courtroom without a lawyer, you shouldn't go into birth without a doula. I got that from a midwife actually in California. Her name is Sumi. But I am a firm believer in the mother needing to be mothered, and you know, the negligence of moms throughout the birth experience is very real, and it's raw and it's tender and it's not fun. It's all direction goes to the baby bump and, oh, are you having a boy or are you having a girl? And just very much baby centered. And so the doula really does give the opportunity for the mom to go inner and for the mom to learn about herself and to allow her, or the birthing person rather, to follow their own intuition, to hear from their own body, to hear from their own baby, which is really the major disconnect, I believe, in birth, in westernized birth. And if you haven't considered it, I'm a firm believer in home birth being a very safe, ancestral, traditional route to take. I would say definitely explore those options of home birth and birth center birth versus hospital birth, because if we look at the numbers and the real information that's out there, hospital birth is a new concept. We were given birth for hundreds of years at home with our families, with our elders, and our ancestors being fully present and just laying that blanket of safety over us for years and years. And now we are our first world country and we are very reliant on technology, and yet we have higher numbers in birth disparity, specifically Black birth, than any other place. And so it just, what is the disconnect there? It's just very interesting to me. And the beauty in this, in being a doula, is that there's really no cap on the knowledge. There's so much information that lives within us as birth workers and womb workers, but the beauty is that there's so much information to be consumed. And the more, I educate myself as a holistic doula, the more I can give to my community. And so I would just say, really look into having a doula, consider and explore the option of home birth, and just making sure I'm not missing anything, but that's very important to me. And also, as far as the future of Black birth, just continuing to lean into breastfeeding as an act of resistance, because we've also gotten away from feeding our babies. Breast milk is free. It is the first food. It's the best option for baby. And I would say look into free breastfeeding, there are leagues out here like La Leche League where you can get, and there's other Black breastfeeding organizations as well that exist. And so just really looking into your community for these womb workers and these people that hold knowledge. And last and finally, decolonizing Black motherhood and releasing the idea to be strong. right? And needing to parent alone. Really just getting back to our roots. We hear in society, strong black woman, strong black woman, strong black woman all day long. And so we fail to realize that leaves an imprint on us, and we feel like we have to, fall into that. And birth is all about being gentle, being soft, and being open. It's not about being strong. It's not about, being this like warrior and putting your dukes up. It's really just about staying soft so that you can release your baby, staying calm. I like to call myself a birth designer because I like to have the room lights low, candles lit, music soft. If that's something that sounds good to you, really, really look into a doula, and also think a little bit more about communal parenting. You can lean on your elders. You can tap in with your friends. You don't have to be alone. That's something that I learned as well as a single Black mother, is that, there is tribe and there is community, but getting so caught up on the strong Black mother concept, I forgot to ask for what I needed. There were people that were more than happy to help me in whatever way I needed. And most of it for mothers is, and new birthing people is, emotional support. That doesn't cost anything. Sometimes we just need somebody to hold space for us. So yes, thank you for your time.
So I'll jump in and talk a little bit about my vision for the future of Black birth. And it's kind of adding on to what Bree so eloquently mentioned, returning to a sense of community. That was our backbone. That historically, that was our backbone, community. That's where we were supported. That's where we were loved. That's where we were taught, educated. And we got many of the skills that we had to be able to continue on and grow and thrive, both individually and collectively. And so I think it's important that we return to that sense of community. Community can be free, it costs nothing, as Bree mentioned, to reach out to an elder, or to reach out to family, or to reach out to not just biological family, but friends as family, things of that nature, and have family and the community support us as well. Birth historically was a community event. It included everyone, family, community, elders, because everyone had a vested stake in this child, in this life, in this family. And so in my vision for the future of Black birth is returning to that sense of community. But I have to also mention that, community and our sense of community in this environment that we live in is a protective measure. And we always have to remember that we are in a hostile environment. I don't know how else to put it, but to be very plain and simple about it, because of systemic racism, and because systemic racism permeates throughout our society. In every system, it exists, it lives. And so we're talking about protective measures for our community, for the Black community, for people of color who face these disparities on a daily basis, who face microaggressions on a daily basis, who face overt and covert racism on a daily basis. So coming together and fostering a sense of community is a protective measure. And we always have to keep that in mind, because I know people say, we have to get to healing. We have to heal. We have to heal. But we also have to recognize that we can't necessarily jump to healing if we are still in an environment that continues to hurt us. And so we have to recognize that for what it is, and do what we can to protect ourselves and protect our communities. And insulate ourselves. And that's just the reality of it. But in the future, of course, of Black birth, my future would be a complete dismantling and disruption of that systemic racism in those systems of oppression. So.
We're ready for any questions at this time.
There's one that's in the chat room, Tommy.
I can't see it.
I'll read it. It says, sure, I'll read it. It says, when you have such strong beliefs about birthing and the after, how do you help moms have their hopes realized without judgment? And what if the mom encounters challenges with breastfeeding and even with the birthing plan that she outlined? Do I need to repeat that, or you guys got it?
I can jump in on this one. As far as supporting moms without judgment, it's really meeting the mother and the family where they are, and offering any help, assistance, aid that we can where that person is right now. It's not about us. It's not about where we think the person should be. Okay, it's about where they are and helping them realize their own goals of where they want to be. And just being a constant support to that mom, to that family. If a mom says, my goal is to breastfeed for 6 weeks, and we have our own personal beliefs that, okay, mom, you should breastfeed for at least 6 months. We need to honor the mom's choice to breastfeed for 6 weeks and continue to educate and encourage, and not impose our biases and beliefs and judgment on mother or that family in regards to what their goals are, because you might be encountering a mom who for generations and generations, family never breastfed at all. So 6 weeks of breastfeeding is extraordinary, so we always have to look at things in context. And we face enough judgment day to day, we face enough judgment. And so that's the last thing that we need to offer to moms and families who are navigating the birth realm and navigating this whole process. We need to offer support, and we need to offer respect. And we also need to make space for their own autonomy and what their goals are.
Very, very beautifully said. Yes. And just to even answer the second half of question 2, as far as if there's challenges around the birth plan that was outlined, I always like to suggest a birth preferences versus a birth plan, because birth is just not it's not realistic to have a plan set in place. I think it's really great to know all options and to, have an idea or a list of what you would like versus what you think is going to happen, because these babies choose their birthdays, they choose to come earthside however they like to come. And so I would definitely consider birth preferences and share that with your midwife, OBGYN, doctor, partner, whoever will be present for birth. I just wanted to share that.
And I want to add in there as well, in all the time that I've practiced, especially doing home birth. I love home birth. And when I walk into a home, I don't have to judge anything. I'm excited to be there as a participant in a birth. And the process of birth has its own energy. It's sovereign unto itself. I'm a servant, and I stay in that role to serve my clients, which are usually my people. And when I go and look in a cabinet, if I don't see something that needs to be there, I just bring it when I come back. I don't have to go into the bathroom. If I don't see something in there that needs to be in there, I just bring it. I don't have to say anything. Within your own human self what gives you comfort, and you can only add that into the process of serving somebody else to give them comfort. I've never seen or felt anyone reject hospitality or love or free hugs. There's a comfort level that comes with some of these things. because we've been pulled out of doing what should have been rites of passages anyway. But once we get back on track, that's what I'd like to see for the future of Black birth in our communities, is rebuilding, restructuring, and that comes after all of the talk that we have so eloquently is going to be the word of the day, because we talked about dismantling and, there's this fire that comes up and we want to run with it. But again, I humbly sit with Bree's, the beautiful picture of not having on the warrior face all the time. Birth is not something we can control. And if you have a birth preference, as she mentioned, you have to always remind yourself too that submission is a part of that. There's some power in submission because you allow yourself to move out of the way and let birth have its way, which is you answering your call of nature. And it's beautiful, especially when you don't have horror stories in the back of your mind and trauma stopping you from recognizing there's a powerful pain process, but that pain is also birthing a baby and bringing that child into a safe space.
I mean, you can't see the questions, correct?
I cannot, and if you would continue to do
Okay, I'll continue to read them then. I think Bree and Waluna, you can see them?
Yes, I can see.
Okay, I'll read them for time. So I'm going to kind of combine these next, I guess it's 3, but they're kind of speaking to the same thing. So, and then if I got that wrong, just correct it, brother. So, okay, so first question is, how does one become a doula and or a midwife? And the following is, as someone wanting to become a doula, is there room for us culturally in Black birth experiences in the Western/mainstream medicine setting? And what are the challenges to protecting Black birth?
Yeah, brother, I think we should break those down.
Yeah, I can do that first part on the doula, midwife, birth worker. 2 words, go within. I'm going to tell you right now, I love that I was able to navigate through the process to become a midwife with a certification and a license, but it was a very humble journey. It was a journey that broke me. It was a journey that also built me and restructured everything about me from the inside out. My own life and my own births were wrapped around the births of my clients. My passions were not fulfilled in the time that I wanted them to be fulfilled in. And then at the very end, everything I ever could have wanted landed right in my hands. It's a powerful journey. And so to begin it, first of all, is to go within and know that this is something you really want to do and can commit to. The second thing I would say is check your finances, because there are avenues. It's as easy as going on the internet and searching for a program or a school and deciding I want to be a midwife and just paying for it and doing it. That's a collegiate type of answer. But again, I'm talking about Black birth work. And Black birth work requires that you be multilingual and your mind be multidimensional, as we are multidimensional beings. And you have to have a spiritual foundation of sorts to really go into birth work. The third thing I'd like to add to that, outside of just going and picking a program and having finances to pay for it, is we must never, ever, ever forget the traditional midwife. They are in our communities today. They're elders. They are matriarchs. I know I looked at this documentary, Sister Waluna had sent it, and it spoke to a great-grand midwife and the many children that were born in that community through her hands, and how they went to her because she was not only a midwife, but what is a midwife? She was the person that fed the children. She was a babysitter. She was a doctor. She was a nurse. She was a counselor, a whole lot of things. That's the true traditional ancestral midwife that every community deserves and should have. And it starts within, even within your own family. Even your grandmother, great-great-grandmother now may have been delivered by a midwife. So that's my contribution to that question.
Yeah, that's good. And to add to that, if I can, as far as wanting to become a doula and wondering if there's room for us, we have to really go inner and push the button of the power that lives within us. Is there room? If there's not, make room. And using the voice and just really tapping into that inner power and just feeling okay with taking up space. There is room. There are multiple doula programs that are rooted in African ancestry and in Blackness. And if I can just have a shameless plug, I want to shout out where I came through, which was Mama Glow. I was trained by the Latham Thomas. If you don't know her, look up mamaglow.com. We have a new training program rolling out in October. So all that information is there, but I chose her program specifically because of her knowledge in African ancestry and wellness and the importance of, being holistic in the work. So yes, there's room. And what are challenges to protecting Black birth? That's a very loaded question. I'm gonna have to sit on that one for a second.
Okay, Doc, I can't see the question.
Okay, we'll come back to that one then. So the next question is, given that many women still give birth in hospitals, what kind of measures can be implemented to ensure that we're holding space for Black and Brown women?
Okay, repeat it one more time for me.
Given that many women still give birth in hospitals, what kinds of measures can be implemented to ensure that we are holding space for Black and Brown women?
Excellent. Hospitals allow doulas. Hospitals allow student midwives, and they need to look like us, or at least be about something that pertains to assisting us. Currently, we have very few options in deciding and determining the treatment plans for culturally astute Black women and partners and birthing people in hospital settings. And when we are met with something outside of the Western allopathic model, they do not move their position or open their position to allow you to have a hot compress on your butt or on your, vagina, since this is a maternal health panel. That's something you should be able to have. You shouldn't have any fear about asking for it. But there's a concern that the lavender oil might smell up the whole hospital ward. Okay, well, is it something that's needed? So it's almost like the preparation ahead of time. You have a lot of power. You have a lot of clout. You have options as a birthing client in that establishment. And you should go in that type of emancipative thinking and honor yourself with making sure you get yourself a birth worker of sorts, more than one or two to counsel with, and activate the plan that you'd like to have in the hospital setting. Again, you can birth anywhere. As you know, babies are born anywhere. You can birth in a taxi, you can birth on a bus. The thing is being clear in your mind and knowing what's going to benefit you, what's the best way for you to honor that process of becoming a parent. So.
I want to speak a little bit to the question, what are the challenges to protecting Black birth? I think that there are both internal and external challenges. I think the internal challenges can be addressed through supports such as having a doula present or having someone who is knowledgeable and informative about the birthing process, about pregnancy, about rights, and things of that nature. But therein lies the challenge externally, is needing to have that person there and needing to have that person present in order to be that advocate, in order to be that support, in order to assist and provide information so that one can be empowered in their birth. And so I think that we do have some internal challenges through lack of knowledge, just lack of knowledge on the birthing process, lack of knowledge in regards to what that looks like when we encounter systems of care, what our expectations are, what we expect of our providers, getting out of this mindset of being allowed to do things when it relates to our birth, being allowed to do certain things within the birthing room, or during pregnancy or during the birthing process, and postpartum as well, and kind of deconstructing that whole mindset. So that is an internal challenge, just education, empowerment, things of that nature. And we do, as Bree and Thomasina spoke to, have supports and have answers and solutions or to that. But externally, of course, challenges are just the environment and providers and the teaching and education of providers, or lack of teaching and education of providers in working with us and in providing services. And so that is a challenge. And then, of course, knowing that these providers operate within a organization or agency or a system or structure, who thereby further define how they operate and how they function and how they practice. And so again, it continues to go back to those systems and structures that aren't beneficial for us, and having to constantly first be aware of those systems, and then put measures in place to work against those systems.
Thank you. Next question is, how can I, as a healthcare worker, advocate for Black women in the birthplace and make sure they're being given proper care while respecting boundaries? Do I need to repeat it?
No. Us three here, we be healthcare workers. I wanted to carefully reply to this because you have heard whoever asked this question, bless you, that the three of us have self-owned businesses. Is that fair to say? So that kind of allows a little more freedom in how we do what we do. Is there an option for you as a healthcare provider to begin your own business? And let's say you are still working within a structure that's already pre-existing, hospital or whatever your healthcare forum is and your audience. Are you able to add a cultural competency component and possibly introduce that idea to those that you work for? That seems to always be a good way to begin an integrative and innovative way of education, so that you can carefully augment a plan to assist within your culture while you're also working. So I think if you really want to put something together, propose it and give it to the right people, that would be another way. You don't turn off just being Black. And so I kind of see it like that wherever I go, whoever I'm working for. So it almost is in the place of you bring what you bring, which came with you when you were hired for the job. And that's something that you don't have to turn off, take off. You can anyway. So just integrate that into your way of wanting to serve and be a part of your community as a healthcare worker, and be confident and always be considerate of your environment and those you work for as your authorities and employees, etc. But yeah, those are just a few thoughts of mine. I'm sure somebody else can add more, but those are my thoughts.
Yeah, I would say, as an advocate is very important to be okay with what you don't know and seeking information or just referring out if you don't have the proper information. I think we as advocates, we feel a lot of pressure of knowing it all, but I think it's a big piece to have a community that you have a Black doula, or you have a Black midwife, home birth midwife, or nurse midwife. Just have those people in place that you can go to either seek knowledge from and learn from, or refer them out. Yeah.
Just to briefly add on, just really quick, just simply, I would say, is to listen, be in tune with whoever your client is and whoever you're working with, or whatever family that you're working with. Don't assume to know their needs, ask what their needs are, and attempt to tap into that, attempt to educate, and just simply, be brave. There are going to have to be instances where you're going to have to be the brave one and stand up and advocate when no one else will. And so getting comfortable with that idea and sitting in the seat of that idea, I believe will prepare you for all that can be ahead.
Okay, next question is, audience member says, I work with many low-income moms. Are there doulas that work for free? And does Medicaid cover doula services?
Bree is all over this one. I can feel it coming through the computer. The answer is yes. I have for over 20 years gave as a first fruits type of offering a free birth, just because it needs to be done. So you can remember who you are and why you do what you do. You just need to do it. That's just the way I roll. And then in recently embarking on the idea of a preceptor position, there are many opportunities if you can get with the right collective, the right collaborative, conscious community organization that might be able to assist you with that. I don't know where you are, but you can always reach out to Sister Waluna here. She's got a lot of connects, and we try to connect all over to plug you in with informative opportunities on free resources through actual having doulas and midwife services. So there's an organization, UBBC is the United Black Birth Collective, and she's a direct contact for that. And you can always send an email and she can give you that. So we can try to help there, but yeah, you can get some free services every once in a while, and they can be quality, and yeah.
Bree, Balloon, do you have anything else to add? Okay. All righty. Next question. How do you grieve when there are significant challenges in a pregnancy?
GRIEVE, grieve. All right. Having gone through a lot of things in my life, I wake up days later, months later, years later, and the sun came out again. But right now in my present mind, I would never mock anybody that's going through a grief situation, because that's very real. I would call a mental health specialist. We just happen to have one here, but whomever. We have two powerful people sitting on this panel for a reason. One thing about grief is, it's a repetitive statement, but you have to meet people where they are. And I just sit oftentimes when I have had to deal with tragedies within birth work. I'm just present. I just make myself present as a conduit for whatever needs to be done for that person to heal and move forward. And I don't know to add to it or take away from it. I just find myself being present. And I have to personally mention, because you brought that question up, that I have learned these two beautiful women through birth work. And I was blessed to have them in my life, but I've known Dr. Corbin for a very long time. And I just sat when I went through my grief, and I learned being present from him. He was just there. So.
Yeah, I believe that birth work on any caliber, or any professional, I would say, especially in this type of work, we have to have therapists in place. We have to have self-care in place. Whatever, I would say, find your form of therapy, because for everyone, it's not sitting in front of a psychologist or counselor. For some, it's acupuncture. For some, it's inner child work. For some, it's journaling. I would say definitely find your path and lean into that, and be okay with whatever your form of therapy is, because there is no right or wrong way. And just really, like midwife Thomasina said, grief is really just a part of it's just a part of life, right? And I like to say grief makes room for joy. It's a part of the Heart Olympics. It's just, we just have to, roll with it as it comes.
I just want to add to that, just to recognize that, grief can be complex, but grief within birth work can be twofold. There's grief on for the provider, who, or the midwife, or whoever was at that birth, whoever witnessed that birth, and provided during that birth, and facing those challenges, and those emotions related to grief when an incident happens or there's a challenge during the birth or the pregnancy. And I always want to kind of advocate for debriefing, coming together as professionals, as providers, coming together, debriefing what happened, what did you see, what did you feel, what could have been better, what were the challenges, and kind of taking that from start to finish and talking about it and being open with our feelings, processing those, validating those, leaving space for those. And as far as for the parents or the families who encounter challenges or and experience grief related to challenges, a lot of times it's this, like Sister Thomasina just mentioned, it's having someone there or feeling heard, feeling listened to, and not necessarily someone doing something or having an answer, but just being comfortable with sitting in those feelings and being a support and saying, hey, I'm here, and for however long it takes for us to get through this, and being a support to that person or that family. And I do feel that if, like Bree mentioned, whatever your form of healing is, whatever your form of therapy is, it does not have to be a therapist. It does not have to be what's deemed as so-called traditional, or it can be whatever your form of therapy is, if it's effective, and reaching out for that.
Yeah, this is a question that I actually could have answered, but no, in all honesty, collectively, the things that Tommy, Bree, and Baluna just said, I couldn't have said it better myself, couldn't add anything to it. So that was perfect. Thank you, guys. Next question is, what are some things that people might not know about a doula's role? I'm curious to this one myself, y'all, just in case you're wondering. Some things that people might not know about a doula's role. Oh, shoot.
Yeah,
Get settled, strap in for this one. So
yeah. Well, I first would say it's still a term that people are learning about in general, right? Like, what is a doula? If you Google it, I believe it comes up as like in Greek, it translates to like women's slave or women's servant, right? But essentially, a doula is someone who mothers the mother. That's pretty straightforward. But our presence has research literally shows that our presence lessens the amount of medical intervention, so the amount of medication that happens during birth. We lessen that. Our presence also minimizes the amount of C-sections that happen. I would say those are like two really big ones. Is just our literally our physical presence, not the knowledge that we have or education or certification, but literally just being in the room. And I think that's really powerful and shows the importance of this concept of presence and how important it is.
I have a little 5-second drop on it. Something that doulas don't do is typically what midwives do, deliver babies. But they do the self-care, the maintenance, and all that other good stuff for the mom. So most doulas are mom-oriented in that way of caring, sharing, and family. But in the traditional model of Black community, a doula is the beginning of becoming a midwife. And so we don't ever block that. We see it as a continuum. There's never a higher up or down. It's an evolving circle of responsibilities and love in a birth. So I need my doula.
This next question is actually for me. It says, Dr. Corbin, how can birth workers do more to include fathers or partners? And I'm only going to echo what has already been said by the other panelists time and time again, which is you got to meet the person where they are. One of the biggest mistakes we make in society is we have what we consider normal expectations for others' behavior, and then we just place that on them. And when they don't match it, then it's punitive or it's disorienting or discouraging. And let's face it, in human nature, people don't like to be told what to do. And men typically run away from expectations that are placed on them without their input. So the way I would answer that question is meet them where they are, engage them, ask them what they are prepared for, what their needs are. How is it best for them to engage? How can they show up? Let them have a voice in that. And when you do that, then they will feel empowered in that process along with their partners. So that's my short answer to that. But yeah, meet them where they are, find out what they're ready for, what they're ready to commit to, what they can do. And then you can use that coaching and encouraging for other areas that might need to be stepped up. So thank you. Next question is, did anybody else, I'm sorry, did any of the other panelists want to add to that? Seriously, go for it, because not just my perspective. Okay, next question is, what happens when these things, doulas or midwives, are cost prohibitive?
Okay, read that one more time, please.
Yeah, what happens when these things, in parentheses, doulas or midwives, are cost prohibitive?
Can I interpret that as cost prohibitive means
I can't interpret that for you, but maybe the three of you can get a sense of what that might mean.
I'm asking the sisters there, can't be paid for? Will Luna help?
Yes. Yes.
Okay, so the question is, what happens when someone can't afford the services?
Well, it says what happens when these things are cost prohibitive. So
okay,
I assume the services that are being offered, but I don't know.
Look, I'm not trying to be funny, but I'm gonna be honest with you. Press it out and get what you want. There's way too many options now. We got the internet. I didn't grow up with any of this stuff, right? So I'm totally blown. Anyone that knows me knows I joke about having a BlackBerry phone. It's not funny, but there's a reason for me staying old school, as in can't afford it. Right. I'm glad I got to that. Thank you, Kirsten, for your help. Yeah, press it out. Type in free get on Google or any other website and just go for it. It's an unlimited supply of information and knowledge. And then put your physical, personal, spiritual energy behind how bad you want it until you get your answer. Those are my thoughts. But there are options out there. There are payment plans. And then we mentioned before with the other question, there are some people who do birth work for free as an honorable thing.
Yeah. And just to add to that, I always love to suggest to expectant birthing people, if they're having a baby shower, maybe have a doula donation box. And I know given right now, the circumstances are a little bit different, but you can say, hey, this is my Cash App, is my doula donation. And baby showers are like a really good time to ask for that. There are grants that are out here if you tap into certain organizations. And like Midwife Thomasina said, you can 9 times out of 10, especially given the circumstances right now, you can speak to the doula or midwife and see what options you have for payment.
Also, too, to add on, I have seen people fundraise for birth services, doula services, midwife services, crowdfund, GoFundMe, all types of avenues. So sometimes you may have to get creative, and there are some free or low cost programs out there. You just have to kind of do your research in regards to where you are, your local area, but there are some free, low cost options for doulas. And as Sister Thomasina mentioned, that for midwives as well, and don't also consider using a student, particularly for doula, not necessarily for midwifery, but especially for doula, someone that is getting certified or in the process of becoming certified. A lot of times they need births. They need the experience of having births. So that can also be an option. And as Bree mentioned, just the presence of having a doula present can be helpful. And so that might also be an avenue that you might want to consider in regards to making it affordable.
Sister Waluna, don't forget to give that UBBC Gmail or email or some contact info.
Oh, absolutely. So the contact information for United Black Birth Collective, which is the collective of birth workers, community birth workers, is ubbcconnect@gmail.com. Please feel free to email if you have any questions, if you want to know about any services that could be provided. But we are a resource for that.
Okay, let's see if we can get this one in. How can a woman determine if using a doula is right for her?
I was looking for Bree. Is she there?
Yeah, she popped off, and I don't know if she had to go or if she lost her connect. But no, she left. It says okay, she left. So how can
always?
This is the last question. So how can a woman determine if using a doula is right for her?
Maybe Sis can put something in here too, Sister Waluna. One way, common interests. Whatever you have as a plan for your birth, because you have to come into it knowing a little bit about what you want, something. You might know what you don't want more than what you do want. And in that case, present those things to the person when you're screening or talking to them and see how they feel about those things. And then politely just, let it be known that, I appreciate your time and your energy and your thoughts. And then if it's just not looking like it's a good fit, never feel bad. There's so many more options out there. So you're not stuck.
I agree. Just really quickly, you have to determine what you want. And sometimes determining what you want is determining what you don't want, like Sister Thomasina said. So you might not have a clear image of what you want, but you definitely have an image through experiences of what you don't want. And seeking out somebody to to help you achieve that and abide by your wishes. And just if you feel like you need support, and you don't have it, a doula can just be helpful. This is something that can just be helpful in general. So.
Yep. So they said that was the last question.
So Kirsten, thank you for having us. Thank you, Doc. Thank you, Aluna. Thank you, Bree.
That was fun. Thank you.
Thank you, everyone. Thank you.
All right. Take care, guys. Bye-bye.
Bye.
Hello, everyone. My name is Dr. Faith Gibson Hubbard, and I serve as the Executive Director of Mayor Bowser's Thrive by 5 DC. Today, I'm joined by Director Jackie Reyes, who is the Director of the Mayor's Office on Latino Affairs. And we are so excited to announce a series on the state of maternal and infant health in the Latinx community. So, join us daily, October 5th through October 9th at 3 p.m. on Mayor Bowser's Mom Health DC Facebook page for a virtual discussion on topics ranging from access to quality care, COVID-19, mental health supports, and more. Maternal and infant health is a community-wide priority that needs community-driven solutions. So let's work together to improve maternal and infant health. This series will be hosted fully in Spanish. And for more information, visit dcmaternalhealth.com. And to share this information about this series, please visit us on all social media outlets at Mom Health DC and use the hashtag DC Maternal Health or DC Salud Maternal.
Hola a todos, soy Jackie Reyes Llanes, directora ejecutiva de la Oficina para Asuntos Latinos de la alcaldesa Muriel Bowser. Hoy me acompaña la doctora Faith Gibson Hubbard, directora ejecutiva de Thrive by 5 DC. Estamos muy contentas de anunciar sesiones virtuales sobre el estado de la salud materno-infantil en la comunidad latina. Únase a nosotras del 5 al 9 de octubre a las 3 p.m. en el Facebook de la alcaldesa Bowser, Mom Health DC, para discusiones virtuales sobre temas que van desde el acceso a la atención médica de calidad, COVID-19, apoyos para la salud mental y mucho más. La salud materno-infantil es una prioridad de la comunidad que necesita soluciones impulsadas por la comunidad. Trabajemos juntos para mejorar la salud materno-infantil. Esta serie se presentará totalmente en español. Para obtener más información, visite al dcmaternalhealth.com, hashtag dcmaternalhealth o al DC Salud Maternal. Gracias.
Please welcome back Dr. Faith Gibson Hubbard, Executive Director of Thrive by 5.
Good afternoon, everyone, and thank you so much for joining us for this 4 days of Mayor Bowser's National Maternal and Infant Health Summit. This is our 3rd year, and it has been by far our greatest. We have built on the model of the past when we started in 2018, 2019, and then this year in a fully virtual summit, we have been able to reach thousands more people within the District of Columbia and beyond. As I said in my opening remarks, we have a phenomenal and innovative leader in Mayor Bowser, and through her leadership and the leadership of Dr. LaQuandra Nesbitt at DC Health and many other agencies, we have been able to do so much, but know that together we can do even more. And so on behalf of Mayor Bowser, I want to thank you for joining us this week, and I hope that you will continue to stay engaged with the conversation through all of the resources at dcmaternalhealth.com and also on the Facebook page. Please share all the different sessions with your colleagues, friends, anyone really, as this year, because we're fully virtual, people can watch the sessions over and over again. Please also keep an eye out for the survey that will come through the Hoover app, and also if you register through Eventbrite, to share more with us about your feedback about this year's summit. And do please I invite you, I guess I should say, to join us for the fully Spanish session that we're going to do in October with my colleague that you just saw us introduce this session just a little while ago. But October 5th through October 9th at 3 p.m. daily, we will have really great sessions talking about the importance of maternal and infant health in the Latinx community. I can't thank you enough for joining us and for really going on this journey with us. Again, I want to thank Mayor Bowser for her amazing vision and also for believing in myself and Thrive by Five, as well as my colleague, Director Lamont Akins of the Mayor's Office on Community Affairs in making this year's summit possible. So again, thank you, and we hope to stay connected.